Yesterday, we kicked off our summit with the screening of the documentary Aftershock, which follows two grieving families who, after losing their loved ones due to childbirth complications, galvanized activists, birth workers, and physicians to reckon with one of the most pressing American crises of our time, the U.S. maternal health crisis. We witnessed how two women, Shamani Gibson and Amber Rose Isaac, were failed by the medical professionals entrusted with their health. Both women complained about maternal health related issues they were experiencing, but their voices were silenced. This growing issue highlights the need for quality improvement initiatives in states, hospitals, and communities that ensure all people who are pregnant or postpartum get the right care at the right time. We also heard from our keynote speaker, Amari Maynard, who lost his partner, Shamani Gibson, to maternal health complications 13 days after giving birth to their son. As Shawnee Benton Gibson, Shamani's mother, mentions in the film, knowledge doesn't save you from the epidemic. We cannot just expect change from knowing there's an issue. We need to act on this issue. We need accountability and we need change. We as public health and medical professionals need to be better and take action to prevent these mothers from succumbing to maternal health related deaths and complications. Today, I'm excited because it's an opportunity for us to focus on raising awareness, building connection, and opportunity for us to galvanize the programs that Harris County Public Health will be launching in partnership with other stakeholders and community partners. Today, we're going to hear from individuals who are going to share data about the staggering crisis that's in our community that's here in Harris County. But before we jump into our activities for the day, I want to take the opportunity to introduce Commissioner Rodney Ellis. He has been a champion of this work, and we're grateful for his leadership. Without his leadership, Harris County Public Health would not be able to launch our Black Maternal Health Summit, as well as our pilot program that we're launching later this year. So with that, I want to give some background on Commissioner Ellis. Before he was elected county commissioner in 2016, he served 3 terms on Houston City Council before being elected to the Texas Senate in 1990. He represented Texas's 13th state Senate district for 26 years and passed over 700 pieces of legislation. As I said, he has been a staunch advocate and supporter of programs that address the needs of vulnerable populations here in Harris County, and we're grateful for your leadership, Commissioner. And with that, please give a round of applause for Commissioner Ellis.
Barbie, thank you, and thank you for your leadership and her entire team. You all do a great job, and we appreciate it. You had a summit not too long ago. You have another one today. It's important. A lot of people talk the talk, but most people wouldn't go out and put the time into organizing. And I'm glad that County Judge Lena Hidalgo, Commissioner Adrian Garcia, and I are willing to support the work that you do, and we hope that we get all of our colleagues on Commissioner's Court to do it, but even if they don't, we're doing it. So this is a pilot program, and I'm sure she'll tell you later we're going to put some money behind it. I'm so glad that, thank you, it's worth clapping on that. Barbie, you know, we love you. I know you're dealing with the family issue there, and I knew Reverend Orange, didn't know his daughter, probably met her when she was young, when I was young and working in Atlanta when Andy Young first ran for mayor is when I met Reverend Orange, and I know his daughter passed, who's one of your dear friends. So you were in Atlanta, got on a plane, came right back. Speaking of health issues and how things can change so quickly. Amari, I'm glad to get to meet you. I'm going to Google so I'll know more about you. I was just whispering to him, by the way, if you all haven't seen those massive murals in downtown Houston, you ought to go and see them. All of them are related to United Nations sustainability resolutions. So it's called Big Art for Big Change. So big murals, but with a purpose. Subtle message you don't always see. And the one that stands out more than anything is a little African-American kid on a bicycle, Amari, because it's fairly uncommon to see someone that looks like you or me or Barbie on a mural. We also have one related, that one is about equality. We have one related to another UN sustainability resolution, and it's a Native American girl on it. it'll be obvious that she's Native American. I was telling the artist because he is Nigerian American. So he made sure there are a few hints in there so she's Native American. There's a South Asian woman on the side of the Four Seasons. And then there is a Hispanic woman on one. And I was just telling Omari, come all the way to Houston, here in Cowtown, and I'm trying to get New York City to agree to put on the side of a building a mural related to a UN sustainability resolution with the one black woman, first black woman to be a part of the New York Ballet, Misty. Pardon my ignorance, but I'm not that cultured. Misty Copeland, who's about 43 years old, look a little bit like you too, by the way. You could pay, if you get your shoes on, you could do it. So now I'm putting you on the spot, Amari. So I'm gonna email you that when I tip out of here, so you can make sure Mayor Adams, when he was Senator Adams, it was easier for me to get to him, since I was a state senator as well. The money, everything is in place. But look, on the issue at hand, this is an important issue. I mentioned to Barbie. It resonates with me personally because a dear friend's widow was having a kid in Atlanta, by the way, of all places. And the only hospital I thought of was Grady. And when we got there and found out 2 kids instead of 1, this is 30 years ago, she's lucky. They were both born prematurely. Luckily, they both made it. Been challenges along the way, but they made it. So it is an important issue to me. Black Maternal Health Summit is important. We're having it here at the University of Houston campus. A lot going on. I don't know if it's homecoming weekend or what, but it was difficult getting it here. We're going to address this critical topic with leadership by putting some money up. I know that the situation is dire because it's particularly grim for black women who are 3 times more likely to die during childbirth than white mothers. And if you are black and pregnant in Harris County, your baby is 1.5 times more likely to be born preterm. And I know we can do better than that. So we put together a program because Barbie insisted on it. She kept pushing to get it done. We're going to focus on black mothers, and we'll pair 300 mothers with community health workers to provide access to both prenatal and postpartum care. Programs like these are even more important in this political climate, where even if a young woman has been raped, she could be forced to term, even if it's incest, to have the child. So programs like this cannot end up on the chopping block. That's why I appreciate the Biden administration giving us ARPA money. That's the money we're using for this pilot program. If it works, hopefully we can make the case when that federal money is no longer with us, so we can do it with our local money. Barbara, I think it's about $4.5 million. About $8 million we're going to put into it. That's pretty good, isn't it? In Houston, Texas, and Harris County, by the way. So maybe Stephen Williams, who's going to tip out with me, because he and I got to work on our old man's health. He put in 50 miles on the bike yesterday. He was bragging about it, but we're going to at least try to get in another 30 today since I'm a little older. But Barbie, thank you for doing this, and her team. You do a great job. We appreciate it. I know the Chronicle might show up, so I'm going to change in my spandex, if that's okay. But we will do that before I have to get on the bike before I finish my day. So Barbie, thank you for your leadership. All right, thank you all.
Now I'd like to introduce our keynote speaker for tonight, Omari Maynard. Omari is an activist, educator, and exceptional artist. For those of you who attended last night's screening of Aftershock, we were introduced to Omari and his partner, Shamani Gibson. In 2016, Omari and Shamani started their own business, Artful Living, a lifestyle and event planning business with an emphasis on artistic expression. In 2019, Omari lost his partner, Shamani, to maternal health complications 13 days after giving birth to his son. After the death of Shamani, along with his mother-in-law, Shawnee Benton Gibson founded the Araya Foundation, which seeks to support individuals, families, and communities who experience the devastating aftershock associated with maternal infant morbidity and mortality. The foundation also provides mental, physical, emotional, and spiritual assistance to support the affected families as they navigate the impact of these traumatic experiences. Throughout the film, we witness Omari keeping Shimani's memory alive through activism and spreading light and positivity through his art to other men in his same situation. Please give a round of applause and welcome Omari Maynard.
Good morning, everybody. It's my pleasure to be here. Miss Robinson, this is amazing. I feel like, we always need to make sure that we're the change that we want to see, right? And that we create opportunities for not just ourselves, but, for our community to be great, and sometimes, we essentially, we create some situations where we don't necessarily always we have the great ideas, but we don't also necessarily put the effort behind it. But once you do that with intention, it's just incredible how the snowball kind of works, and then how you start to meet different people who are doing different things, who want to support but just don't know how to support, and when you create those opportunities, we essentially get this, the first Black Maternal Health Summit, by Harris County at the illustrious University of the University of Houston. Like, it's a special moment. This is a special time, and I am honored to be here for the first one, and I'm just so excited to see how things unfolds for you, Miss Robinson, over the next 5 years, and how you've just come to Houston so soon and have done so many radical things already. It is it's a beautiful thing. It's inspirational. Well, thank you. So I am here today with you all via Shimani Gibson. Shimani Gibson was my life partner, is my life partner. We've had a beautiful relationship, and we continue to create and have a beautiful relationship. She is the first person, or the first ancestor that I've had the opportunity to create a spiritual connection with. And as much as I know she is definitely here in this room, she is definitely thankful for your presence as well. And she is guiding me, my family, and also our community, to make sure that she continues to provide opportunities for us, to change the world, essentially. Maternal mortality is such a huge issue because of the fact that when we're talking about, the Black and brown family and all the unfortunate intersections that we have to face due to systemic racism, I think of all the different levels of hurdles, essentially, hoops we have to jump through, right? So maternal mortality is a huge issue. Infant mortality is a huge issue. I spoke about this yesterday. Gun violence is a huge issue. Food deserts, huge issue. Incarceration, school to prison pipelines. I can go on and on. But regardless of the fact, like, even though we do have these obstacles, and Black and brown people, unfortunately, are at the highest, risk of being involved with, the things that I just mentioned, we're still out here doing amazing things, and really looking forward to and figuring out, how we can create a better future for our children. And that's what essentially the ARIA Foundation is, and what Shimani wanted to make sure that I had the opportunity to be able to be a part of while I'm still here on this earth plane. Commissioner Ellis spoke some numbers, but I want to give you guys a couple of more. Black and brown women are 3 to 4 times more likely to pass away due to maternal mortality than any other of our races, unfortunately. In New York, we're 8 to 12 times more likely. In New York City and the Bronx specifically, 12 times more likely. And, Harris County, it's unfortunately, even though, this East Coast, West Coast, this is not only countrywide issue. It is a global issue, right? So, New York City and Harris County, we're dealing with the same issues essentially, and it's really important that we figure out ways and avenues in order to, kind of turn this ship around and make sure that we are giving our women and also our children a chance to have life and be, be families. For me, Shamani Gibson, she means so much to all of us now, which is super dope, but essentially, like, she was my life partner, and we had plans to have not just 2 children together, but multiple children. I didn't know this, but she actually told her mother, Shawnee, that I want to say maybe 2 or 3 days after Kari was born, she was planning on having another one, and unfortunately, the medical system took that away from us. And it's so important that, of course, we have 2 beautiful children here today, and I look at them and see so much of their mother, but at the same time, we've all been stripped of a relationship that we found and we needed, and that's why I also speak to them specifically, my children, about making sure that, they not only speak their mother's names, but that they also continue a relationship. So with that said, like, I urge you, everybody here, if you don't have an altar in your house or a space to be able to not only build a connection with your ancestors, but also to, create a place for you to learn more about yourself, I urge you all to put an altar in your house, in your space. With our altar, it's an excellent thing because of the fact that, it's not just for me, but my children are, when they clean it, when they change the water on it, when they put food on it, when, we light our candle, they know that it's for a purpose, right? And they know that when they're doing these things, that they're speaking with and, connecting with their mother. And we can all have those opportunities to do that, because when we do that, it's the same way when we build personal connections, right? So I'm here today, via Miss Robinson, and I've met so many other people. And it is the same exact thing when you start calling on your ancestrals, to help guide you. You gain these antennas, right? And you gain these opportunities, and you have these insights and callings through them, and that's the only reason, honestly, why I'm here. So again, I urge you all to do that. As a father, the reverberations of losing a partner, while actually bringing new life into the world, it's a heavy load. It was the first time where, I felt, what really grief was, what real sadness was, what depression was. And through arts, through community, is the only way that I was able to really take a look at myself and a look at what's happening in our world, and figuring out a way to create pathways and open up these connections. So what art has done for me is it's allowed me to, and I spoke about this yesterday as well, it's allowed me to take my low vibrational energy, my grief, my sadness, which are very powerful energies, powerful, right? It's taught me how to take those tough times and then wheel them into something beautiful, into something that allows for myself as well as the world to heal from. I feel like art is a saving grace for all of us, and it's so important that we take the opportunities in our own life to build spaces of creativity, whatever those creative outlets look like. So I'm a visual artist. As I learn to, as I move around the country and have an opportunity to do these panels and have discussions and create conversation, I've learned to become a better linguistic, which is also an art, but having the opportunity to create cinematic films and be a part of that, again, all of these things are all pathways in which we can educate each other in a way that is not static, right? And in a way that allows for stronger personal, emotional connections to be fostered. And when you are driving and moving, your life through these emotional connections, it creates a different type of feeling when you are able to see spaces and places like this, right? When we're doing our own things as an individual, sometimes it works, most of the time it does not, right? You have to have community. You have to have partnership, and you have to create the opportunities for and the space for it. And the arts have allowed me to do so. So again, one other thing that I urge you all to do, whatever it is that is in your personal wants and desires to try to perform, do it. We know regardless of whether it is visual art, sculpting, writing, or just, building personal connections and relationships. Like, please, 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 man, make sure that you do it. Because, like, I honestly feel that, especially in these times today, we are moving in a way in which can be robotic sometimes, right? We are inundated in a world that forces us to look at time as something that can only be, or efficiency can only be created in blocks of time, right? So I'm doing my 9 to 5. I'm raising my children, or having my children come home from, 6 to 7. I'm cooking dinner before I turn around twice a day is over, right? And then we get caught up into that cycle. But if we're not allowing, if you create the space for creativity to live there as well, you can learn how to navigate it in a different way in which, you're fulfilling yourself, right? And that is pretty much the key component to that, right? The fulfillment of yourself. Once you're able to do that, then you're able to go out into the world and provide space for fulfillment for others. And then we can create reciprocal relationships. So I'm looking forward to not only working with Harris County today over these next 2 days, but creating a long-term relationship, because that is the way that we can move forward collectively, So with that said, Ms. Robinson, whatever you need from the ARIA Foundation, from me, from Shawnee, we're definitely going to be here to make sure that we create those opportunities to support each other in ways that will allow for growth and change, because we need it. When you're urged to figure out a way to support your family without, the partner that you have expected to create this life with, it really forces you to look outside of yourself, and lean on community. And it is so important. And this is the great thing about, the pandemic, is that it forced us to use Zoom, right? It forced us to build relationships in different ways, right? And it gave us opportunities to not have to work in silos anymore. And that is exactly what this is, and Commissioner Ellis talked about it earlier, just, being a New Yorker and having an opportunity to build with you all out here in Houston is so special, it's so special. And it's only done because of the fact that now we have a different way to navigate the world. So instead of operating in these silos, it allows us to create space for Harris County to come down to New York to do some dope things as well, and then us again branching out globally. Excuse me for 1 second. And one more thing that I wanted to talk about is how me experiencing my deepest grief has allowed for my greatest growth, right? And I alluded to this yesterday shortly, but we all go through our own personal traumas. Mine's, from the maternal mortality perspective, was at the far end of the spectrum, where I've lost my partner and have had an opportunity to use her loss as a way to, again, build. But unfortunately, that's not the case for most men that I speak to. When we talk about these numbers, 700 to 900 women pass away due to maternal mortality, and when we're talking about maternal morbidity, those numbers, they multiply to 3 to 4 times, right? And when we're talking about near-death experiences, and unfortunately Black and brown women having the highest rate of these near-death experiences. We're talking about, not just personal traumas and generational traumas, but we're talking about how when we're experiencing these griefs, we have to create the outlets and the opportunities in order to move through them. So for me, when 700 to 900 women pass away, that means 700 to 900 fathers are left without, their support system. That means that 700 to 900 mothers are left without a daughter, aunts, sisters, community, essentially, right? So for me, when I was figuring out how was I going to be able to not only turn these numbers into these statistics into ways on how to humanize them, but also to provide supports for people who need them, as such as myself, because I know that for me, that is the only way that I was able to get out of those dark spaces, and people reaching out to me and giving me an opportunity to speak and have an outlet of communication. So we created, in the ARIA Foundation, we created our men's group, and our men's group is called Luxor. And essentially what Luxor is it's a temple in Egypt. And if you look at how the temple was constructed, the numbers are off, the doorways are leaning, they're tilted a little bit, and it looks like it wasn't made to mathematical standards that Egyptians, created their other temples. But in all actuality, it's all about perspective. So when you look at these doorways and they're leaning and tilted a little bit off, when they're aligned exactly right, you notice that the entire edifice of this temple is done exactly the way it was supposed to be done. And the reason why I bring that up is because for me, in our men's group, it really does represent how we all come to with our personal inconsistencies, right? We all come together with our personal traumas, and even though none of us are perfect, when we align together, we create perfection, right? We create these opportunities to be vulnerable. We create pathways in order for us to not only be vulnerable, but feel comfortable enough for us to be able to speak to the things that we necessarily hold close to us, because we don't know how society will look at it if we were able to talk to, if we had the opportunity to talk to other people. So when we create this safe space, it allows for our own personal inconsistencies to create something, like I said, that is perfect. And that is essentially what the Luxor experience is. And I bring that up only because of the fact that for us as individuals, when we're going out into the world and we're creating, whatever organizations or whatever platforms that we want to, it is so important to allow for those type of spaces to happen, because that's when you really start understanding who people are and how closely connected we really and truly are. We hold a lot of things in because of the fact that we think that people will not necessarily understand where we're coming from, but that is not the case at all. When I was Charles Johnson and Mustafa Shabazz, they're two men who reached out to me through Instagram, essentially, and heard about my story and had an opportunity to speak with them, which was powerful because they also lost their partners. And for me, it was important because when you lose somebody, even though, my family is tight-knit, I can talk to my mother and my brother about anything, but for this particular case, I knew that anything that I said to them, they really wouldn't understand, right? And these two strangers reached out to me and gave me a pathway in order to really have candid conversation. And I bring that up because the only thing that I felt like I could do was pay that forward for somebody else. And that's how I met Bruce McIntyre, who is also in the film. I bring all of this to come up full circle because of the fact that when I was having conversations with him and I told him about how I was feeling about Shamani passing, and he was telling me about his partner Amber, he shared with me that he had to bury Amber on his birthday. So it was, when he told me this, it gave me goosebumps because I had to do the same exact thing. Shamani passed away October 6th, and I had to bury her on my birthday on October 11th. And when you go through something heavy like that, you think that there is nobody on God's green earth that will understand exactly how I feel and know what I'm talking about, because sometimes you just don't even have the words to really express it. And the only reason now that I know that I am on the exact path, I met Bruce and he went through the same exact thing, and the only reason why we were able to even know that is through the power of communication, right? The power of being vulnerable, and with that, it really set the table for us to come as men in the maternal health space that, unfortunately is, heavy, heavy female energy and heavy female presence. And I feel like for us as men, it is just so important for us to be included in the space in order to help out in ways that, to make this movement even stronger. So that is really what me and Bruce, as well as other men too, but me and Bruce specifically, are thinking about all the time. Because like I originally said, when it all comes down to it, when a black woman passes, it is essentially the family that has to suffer, and in order to fortify the family, we need all the components of the family to do it, and that is the father as included as well as in the mother. So again, thank you for just having me here. Thank you for allowing me to have conversation with you, allowing a black man in this space to really help out in any way that I can support black women and black families and BIPOC families too. And essentially, when we're talking about capitalism in America, and the BIPOC family being the one that's most affected, please rest and be assured that when we're talking about government and capitalism, it comes down to money, right? And even though we are the highest rate, our white counterparts, it's y'all are close behind, and it's a sad, unfortunate situation. But I say that to say that we all need each other. We all need to make sure that we are supporting each other in this fight. So just thank you for being here. When you step out into the world, this is for everybody. Please have conversations. If you're going into your OB visits and you're not exactly sure what to say or what to do, ask that doctor if they've seen aftershock. Ask the nurse if they've seen aftershock. Ask that OB, because that opens up a different conversation, because they know that you are provided the information that you need in order to make sure that your life is treated the same way as anybody else's. So just thank you again for having me. I really appreciate it. Thank you.
Good morning, everyone. Thank you, Amari. Okay. Like Amari did mention, please have these conversations at home. If you have not seen Aftershock, it is available on Hulu and Disney Plus. And Disney Plus. Great film. My name is Michelle Harrell, and I am the consultant for the new program that we are trying to establish here in Harris County with the Black Maternal and Child Health Program. And for this day, I know it's early and I'm very glad and happy to see you all here, but this is a very, very important topic and it should definitely be discussed in every room. It is my pleasure to introduce our next speaker, Dr. Erica Brown. She serves as the Division Director for the Community Health and Wellness Division and Harris County Local Health Authority. Welcome.
Thank you, Michelle, and good morning, everyone. So it's important as we get started with our summit today to really frame the conversation around the data for Harris County. So we'll get into that for just a few minutes, again, before we start the conversation. The first thing we need to do is establish the definitions of what is maternal mortality, what is pregnancy-related mortality, and then as well, pregnancy-associated mortality. Because depending on the data that you're looking at and how it is defined can give you different numbers, and you need to be aware of the context in which we're speaking. So when we talk about maternal mortality, that specifically is death during pregnancy up to 42 days, literally 42 days postpartum. But when we talk about pregnancy-related mortality, that is death that is related to pregnancy up to 1 year postpartum. And so when we begin to explore what is happening to our black mothers beyond the immediate postpartum period, as we'll see, we've discovered some data that shows us that the problem is not just specifically related to the medical aspect of it, but goes much further beyond. The last term that you see on the screen is related to pregnancy-associated mortality. And this is, unfortunately, anyone who happens to be pregnant and passes away, but not necessarily related to pregnancy. So the first thing that we need to take a look at is specifically what is the state of maternal mortality, so again, within the first 42 days, in the United States, in Texas, and here in Harris County. And as you can see, unfortunately, here in Harris County, we have the highest rate, even above the United States and above that of Texas at 29.3%. When we get into, again, specifically black maternal mortality, so again, the previous slide was maternal mortality for all races. When we get into black maternal mortality, the differences are even more staggering. When we look at Harris County in particular, you can see the yellow line there. We have an 65.2% rate for those black mothers in Harris County. Unfortunately, black mothers are 3.5 times more likely to die in Harris County as compared to the United States and then also in our own state of Texas. Moving a little bit further down the continuum, again into pregnancy-related deaths, when we talk about within the first year postpartum, you see along the side there some leading causes, and these are just literally medical diagnoses that are captured, unfortunately, from the death certificate, but they speak to a much larger problem. When you look at some of these diagnoses, for those of us in the medical field, these don't just happen overnight. These are conditions that have been chronic for some time and contribute to the diagnoses, the causes of death that you see there. And again, even for pregnancy-related death, you see that unfortunately Harris County's pregnancy-related causes of death, or death rate, is 83.4%, meaning within the first year postpartum, Harris County has some of the highest rates of pregnancy-related death in the country. Excuse me. So that really causes us, again, to take a look at what is happening outside of the realm of the immediate pregnancy term. Meaning that from the time a woman finds out that she's pregnant to the time she delivers to the definition of maternal mortality, 42 days passed. There's clearly something else happening that contributes to these outcomes that is not just medically related. Certainly medicine plays a role in it, absolutely. But we have to look more upstream and downstream about what is happening in our county. So just some statistics here. Black women in Harris County access prenatal care less than their white and their Hispanic counterparts. And so we could say that it's because there's less access to insurance. However, the data shows us that those who have the least insurance are Hispanic women. Black women are not far behind, but they are not those who have the least insurance. But yet they access the emergency room more than both their white and their Hispanic counterparts. In addition to that, when we look at how many women of different races are having babies, white women are having more babies than black women. Hispanic women are having the most babies. But again, black women are accessing the emergency room disproportionate to both of their counterparts. When we look at the incidence of chronic disease, Black women have a higher incidence of obesity and hypertension pre-pregnancy and after pregnancy, again, than their white and their Hispanic counterparts. When we look at social services, we talked about the insurance rates, but what we also find is that Black women and Hispanic women are accessing social services at about the same rate. But again, we're finding that Black women's mortality rates are higher than their white and their Hispanic counterparts. The next thing we want to take a look at is how is this affecting our infant mortality rate? So obviously we can't discuss maternal mortality, pregnancy-related mortality, without discussing our infant health as well. What we see is that in the United States and in Harris County, Black infants are twice as likely to die. One of the things that I want to draw attention to, though, is that if you look at the light green versus the dark green, you'll see that although totally unacceptable, Harris County is on par with the United States in terms of their infant mortality rates. But when we compare this to Black infant mortality to Black maternal mortality, again, you see a huge disparity. So while it is again unacceptable for our infants to be dying at such an alarming rate, for whatever reason, our Black mothers are dying disproportionate to the babies. So what can we do about this? According to the CDC, more than 80% of pregnancy-related deaths are preventable. So we must look both, again, upstream and downstream and start the conversation for Black and infant mortality. Public health, this is a public health crisis, and is certainly a public health crisis in Harris County. And for the first time, Harris County Public Health has developed a program to help Black mothers get a healthy start. This program requires all of us to collectively contribute. As we have seen, the issue is not just one of medical care in the moment, but it is a socioeconomic contributions, both upstream and downstream, that will have lasting effects and improve the outcomes going forward. Thank you for your time.
Thank you, Dr. Brown. Okay, so we will go ahead and take a 10-minute break, and we will start back shortly. I will be back on the mic and let you guys know when we are going to start within the 5 minutes. Thank you.
Okay. Good morning again, everyone, and thank you so much for joining us, taking some time on this busy Saturday, clearly, for speaking with us today. I do want to take a moment and ask you to, again, introduce yourselves and tell us a little bit about what you do. Right here is fine. Hello. Hello.
Hi everyone, my name is Dr. Temitope Ekwo. I am an OBGYN at the Women's Hospital of Texas. So I do primary OB obstetrics and gynecology at the Women's Hospital of Texas in the Med Center. Thank you. Mm-hmm.
Hi, good morning. Good morning. Can you hear me? Good morning. I'm Dr. Efoleke. I am an assistant professor at OB-GYN with Baylor College of Medicine here in Houston. My clinical practice is entirely in Harris Health System at Bentab Hospital. I trained here at Baylor and then fell in love with Bentab and stayed here since I joined the faculty I became their Chief of Service for Obstetrics in July, and I'm really excited to be part of this really important conversation.
Good morning. My name is Dr. Angela Burgess, and I am a maternal fetal medicine specialist. So my job, for anyone who doesn't know what a maternal fetal medicine specialist does, is that I inform OBs on how to take care of their pregnant patients. They send me their patients for high-risk pregnancies, women who have diabetes, hypertension, cardiac disease, and various medical issues. And then I direct care and help OBs in terms of directing their care. I'm also the maternal fetal medicine director at Southwest Hospital. So I run the obstetrics unit there, make sure that on a systems level that we're providing the best care that we can for our patients. And I'm also vice chair of diversity, equity, and inclusion at University of Texas Houston Health Center. And so, my focus there has been really to help providers understand our own personal biases, make sure that we're aware of that, and also being really involved within the community is very important to me, and very important in terms of getting our faculty members, our medical students, our residents involved within the community so that we're all aware of how we need to, develop and grow together. Thank you.
Good morning. I'm Dr. Lolani. I am an OBGYN and medical director at the Hope Clinic. The Hope Clinic is an FQHC, meaning that we get federal dollars to help take care of underinsured and uninsured patients. Most of our clinics, we have 5 locations, two of them are in Aldine, but the rest are all in the southwest part of Houston. I worked in private practice for about 4 years when I decided that my true passion was taking care of the underserved women of Houston. So that's when I went to work for another FQHC. I actually went to work for Harris Health for a few years, and then another FQHC named El Centro de Corazon, and then came to Hope Clinic about 7 years ago, where I've been serving as medical director for 6 months.
Okay. Can you all hear me with this? Okay. Thank you all so much for joining us. We'll get started with the first question. How would you describe the Black maternal health crisis in Harris County?
I'm happy to get started. I think Dr. Brown essentially told us what the crisis is in numbers. And so working, especially at a safety net hospital like Ben Taub, this is day-to-day, every day seeing this. We take care of about 15% of our population is African American. But when we look at our data and look at our outcomes, the same disparities that you see in statewide data we see in some of our conditions. We track these on a month-to-month basis. And so even just the awareness of that and taking a better look at it makes it very obvious that there is a crisis and that we all need to do better. So I think it's very clear from the numbers that we saw that there's a problem, but I think all of us as providers see it when we are taking care of our patients and walking from this room to this room and noticing that there are differences in the outcomes and there's a ton of factors that we will talk about that go into it, right? But for me as a provider, it's very much a day-to-day reflection of what we saw in the statistics.
Yes, I'm happy to answer as well. So definitely, it's dire. It's dire everywhere. And we are definitely not excluded from that. It is a multifactorial issue. And I think that we're all aware of that aspect. And it's really looking at how we can not only identify the issues, but also keep track of what's happening as well. One of the things that I focused on in Southwest, not just looking at the personal experiences that I see every day, but also as well as making sure that we're tracking accurately. Are patients coming in when our data comes in and then someone fills out that racial/ethnicity factor, are they writing someone is African American? If they're Hispanic, are they writing white or Hispanic? And then if you're Hispanic, you may also have you may have like a full identity. Are we just using one racial liner? So I think that's important in terms of being able to track our outcomes, really take a look at that, and then of course looking at the separate factors that are related to the issues that we see: the hypertension, the diabetes, the maternal hemorrhages, the things that we know really do lead to morbidity and mortality within the community.
Yeah, just to echo what Dr. Burgess was saying, the numbers are unacceptable, and it's high time that we start upping our game in addressing maternal death, maternal and infant morbidity, mortality. And I think this summit is a great start. We just have so much more work to do, educating our colleagues and our patients and hospital staff, and so much work to do.
Yeah, I agree with what everyone else is saying, whether it's private practice or, FQHC's training programs. It's very important for us to really educate our Black mothers on how important it is to get care, but not care halfway through the pregnancy, to start from the beginning. Because I notice a lot of times, even in private practice, when I have first-time mothers or returning mothers, a lot of times they don't seek care until it's a little too late for us to even, help them make a difference in that specific pregnancy. So I think the biggest thing is education and outreach.
Thank you. Next question. How has this public health as a provider?
I think it's made it really difficult, unfortunately, to give adequate health care. And like I said, a lot of times it's because the point in the pregnancy that they present. So like patients who have high blood pressure or diabetes or a number of chronic health diseases, a lot of times we want to catch them very early in the pregnancy so we can actually make a difference and improve the outcome, like send them to people like Dr. Burgess, so that at the beginning of the pregnancy, things that we can positively affect, we can. But a lot of times by the time they've come to us, they're too far in the pregnancy for us to do, whether it be necessary tests or starting them on medication that can give us the positive outcomes that we want at the end of pregnancy. I think that is the biggest hurdle to overcome.
For me as a provider, what's changed is, well, along with the increase in the rates, I think most people are aware that over the last, it's probably been 12 years or so that that decade increase has been tracked in the U.S. And when I came out of residency, this conversation was not happening, right? So maybe I'm aging myself a little bit, but we were talking about, yes, maternal mortality, but we were not talking as much about disparities and which populations are affected. And so as a provider, what has changed is, yes, we need to have the conversations, and I'm listening now, especially in an academic setting. I'm very privileged, I feel like, to be able to hear a little bit more about this. And over the years, started as a junior faculty member, we started having these conversations about, well, it's not just that maternal mortality is increasing, it's that there are groups that are disproportionately affected, including especially our Black mothers. And so that awareness started to increase, along with, of course, the trends that we were seeing nationwide. And then you start delving into the state level data. So I think as a provider, what has changed is, one, awareness, right? And so what does that mean, awareness? Awareness now for me is, if I have adverse outcomes, which all of us here practicing will have adverse outcomes. It is the nature of medicine, it's the nature of health. But when we do encounter them, personally, when I have an adverse outcome now and it's a Black mother, it hurts a little bit more, right? I do not want to be the person who is contributing to the statistic that I am now becoming more aware of. So I'm glad that the conversations are happening more. I feel like my residents that I work with every day now are much more aware about the things that we talk about, implicit bias and managing that, and how does it affect this patient in room 6 that is having postpartum hemorrhage, and am I listening to what she's saying? and the different strategies that we'll talk about that we're all at different levels trying to do to mitigate this. But as a provider, what has really changed is the awareness, and then how I am taking myself into the room to manage this patient based on that awareness.
Definitely, I agree with Dr. Leke on the awareness aspect. I would say for myself, it's definitely been a personal journey. I take it extremely personally. Just for example, one of my very first, prior to getting into residency, one of my best friends was having her baby and she wanted to have a home birth. And she kind of had a provider, but didn't go to a medical provider. She went to just mostly her doula because of the fear of the bias, because of the fear of what would happen. But then when we get to the point, and I was there just to support her, but then when we get to the point of now we're, pushing for 3 hours, this baby's not coming, and it has become an emergency, what do you do? That's where I had to step in as someone to help her go to the hospital, ask the appropriate questions, make sure that she was able to get that cesarean section that she needed. And so knowing it personally, how it's affected my friends, family members, the not being able to trust providers for good reason, but seeing how delaying that aspect of care can really negatively affect the outcomes as well. I take it extremely personally. I guess my goal as a provider, since that really has shaped my career, has really been to be very direct, be very informative to my patients, and then be very direct to my staff. For example, I've said, hey, you all have had a problem with these patients. Do you notice that they're all the same color? So then what's the issue? These are conversations that I'm willing to have because I think it's important on both of our sides to be able to be open to those biases, see how they're affecting care, because that's the only way we'll be able to address them.
So the way it's affected me, I would say personally with my patients is being more aware. I'm trying to, really talk to my patients. Sometimes we get bogged down as providers trying to get through our schedules for the day and just look at the vital signs and look at their BMI and listen to the fetal heart tones and measure fundal heights and make sure they've had their ultrasounds. But sometimes we need to dig a little bit deeper. So something that I've been trying to do is, ask my patient, well, how are you doing? And she says, okay, I'm doing fine. And I say, no, how are you doing? Like, how are you really doing? So we want to get into mental health. We want to get into, as Dr. Brown suggested, the social determinants of health, asking them, do you have food? Do you have the food that you need to eat nutritiously? Do you have access to transportation to come to your visits? Because one of the main things that I've noticed is that patients don't have the means. They may have their Medicaid, but they don't have a way to get to their appointments. So sometimes we need to assist them with transportation. What is your living situation? Do you need help with your rent? I have a patient currently 18 years old, pregnant with her second child, still living at home with mom, and she and her baby are sharing a very small bed in a small bedroom, and dad has to live somewhere else, lives with his mom, and we have another baby on the way. So I said, well, let's look and see if we can help you get your own place. So addressing all of these other things that are just, digging a little deeper.
Thank you for those responses. Your insights highlight the need to go further upstream to social aspects prior to pregnancy, and then as well, not just the medical aspects of pregnancy, but the social aspects again. So thank you for that. Oh, it came on. Okay. All right. Next question. But the social factors that are having an impact.
I'll start. In terms of social parts, one of the things that we've all kind of said or discussed is one, I do see a large distrust of the medical community. And, I say that in terms of I do understand. There's reason for it. There's the Tuskegee experiments. There are things that are going on now. There are situations that, a lot of people have experienced. And so the direct factor that leads to that can cause a problem is leading to late prenatal care. So then what happens is that, there's distrust. I'm not going to go see the doctor. I'm not going to go see the doctor. Or everything is fine. There's, some denial that we all experience as well. And then by the time it's time to go to the doctor, then that's when there is, finding that this person has poor heart function, or their diabetes is so out of control. Now, other things are happening. And so then that is a large factor that I do see that plays an important part. One of the other things that we were all discussing, which is also why this forum is very important, is the amount of disinformation that's out there. There's multiple platforms, social media, there's Facebook, Google, now we even say Dr. Google. There's something called Clubhouse, there's TikTok. So there are people who go on there and, they discuss a factor, or they tell you like vaccines are terrible, so you shouldn't get a vaccine. But yet we see that our pregnant women, our Black pregnant women, were dying at alarming rates, or were in the hospital at alarming rates with COVID, without getting vaccinations. And so it becomes, almost like a self-fulfilling prophecy when you have the distrust combined with going into areas where you're not getting the right information. And, part of us being here as providers is to show that we are here. We are Black and brown providers that understand, who have had shared experiences, who've had experiences with the patients. And if we can have an open dialogue and communication with our patients, we think that that'll partly, definitely help to alleviate some of what we experience as well.
Yeah, so on a social level, I would agree that there's a lot of mistrust of the medical community, and so gaining our patients' trust back, I think by, having providers that might understand where they're coming from and that look like them and that they can trust, I think is really important. But I also wanted to mention, I think one of the social factors that we also need to address with chronic racism and chronic stress levels might be contributing to our maternal health in our patients. And so I think educating ourselves and training on implicit bias is also very important.
Here, I think they asked me to use this one. I don't know if that one is picking up as well. Can I have that one? Thank you.
Just to add a little bit, I agree with what has been said. I think the one thing from a social factor that I think is one of the biggest limitations I see in my population is access. And so that definitely leads into all the other elements. And so if you are unable to secure funding to get a prenatal care visit until you're 35 weeks, like my patient yesterday who is on her 6th pregnancy and tells me she paid for a visit early in the pregnancy and one ultrasound, has a thyroid disorder and has been off of medication but couldn't get funding until I saw her at 35 and 6 yesterday. I have no way to, in 2 or 3 weeks before she delivers, makes the adjustments if there was any medical related effects on her fetus or herself. We are almost at delivery time, and her only limitation really was I could not get care. I wanted to get care, I could not get care. And yes, with Harris County being one of the biggest counties with a lot of uninsured or underinsured people, and working in the safety net system, I think that becomes very real to us. It's not because, or the generalization sometimes that people don't want to or just ignorant of their health in general. A lot of times it's the limitations to getting care, and those are largest systemic issues. It comes from poverty levels, where again Harris County is significantly represented in that realm. It comes from structural racism, like Dr. Lani alluded to. It comes from your long-term health, which we're always trying to work on. So all those things play into it. Comes from our funding or just where maternal care is as a priority in this country, in the most developed country, compared to other places. And so there are all these layers that then lead to the real life experience of getting care at 35 weeks, and it's hard to then modify the inherent medical factors that go with that.
I think I echo what everyone says, and I think in my practice personally, the biggest social factor that causes me the most issues from appointment to appointment is where my patients are gathering their information from. A lot of times I feel like the most educated patients are at times the hardest ones to educate because they do their research, whether it be from Dr. Google or WebMD, where they think these are reputable sources. They sometimes outdated, but factual information, but not up to date with the information that we have that we're constantly keeping up with our CME. So a lot of times I think that's the hardest, because I'll recommend something for them and they'll say, well, when my mom was pregnant 30 years ago, this isn't how they did it. Or my sister who was just pregnant, her doctor did X, Y, and Z. Why aren't we doing it like this? And so a lot of times I feel like it's a constant battle with these patients, because I am trying to do what's the best for them, because each patient is an individual. And I think that's always my hardest thing. Or, oh, I saw this on TikTok, X, Y, and Z. I literally hear that, I think, five or 6 times a day. And so then I'm taking all of this time that I should be educating them, kind of going and undoing a lot of the misinformation that they're hearing from the internet, whether it be TikTok or Facebook or Instagram. So I think that's my biggest hurdle, is I am really trying to do what's best for you, but they gather information from other places and apply it to themselves, and a lot of time it's not applicable in their situation.
Thank you. So piggybacking on this question a little bit, you touched on the social media aspect. And so the next question is, how can interprofessional collaboration improve maternal health on a systemic level? What does it look like on how community partners, other than the medical community, can assist in establishing trust, can assist in providing accurate information, can assist just in all of those social needs that the clients may have?
Again, it's getting the information out there. For me, I know once I started hearing a lot of patients who purposely come to me because they say I look like them, and they are more trusting of me because I can sit down and talk to them from a patient level or from a physician level, I gain and garner that trust. And I realized how important it is for me, if I am sending them to other providers, that I'm also sending them to providers that look like them, since that is so important to them. So over the years, I have created a list, whether it be medical or non-medical, patients who are looking for doulas or maternity centers. I remember this one patient, it'll stick with me forever. She asked for information on a maternity center because she was looking just for classes and a doula, and at that time I had just entered this particular private practice, and so I was using the list that all of my partners were using, and she came back a few weeks later and said, I looked at the website and no one looks like me. And I was like, man, that's why you came to me, because you're looking for people that look like you. And so that has really forced me to create what's the word I'm looking for? People that I use, people that I refer to, that also are going to treat my patient and have experiences that I have, so that all of my patients, when they're going somewhere, they know that they can trust that those people are going to treat them the same way I treat them. They're going to have the same desires for positive outcomes. They're not going to have the racial biases, because they know that if I'm sending them somewhere, I'm sending them to someone I trust.
For interprofessional collaborations, I think first, as providers, from the medical side, we need to recognize what our roles are. I think once we know what our roles are, then we can know who are the people to collaborate with. If I know that my role as a physician or as an OB-GYN is I can take care of a woman, if she needs to, I can be a surgeon for her, but also understanding that she may not need that. She may not need augmented labor. She may not have, and our goal is really like, she may just need to just come in and deliver, or she may need a little bit more support than I can provide, or am I the most appropriate provider for her if I have a high acuity patient, and if she would be much happier with a midwife, or and integrating those services. So I'm lucky that I work in a system where we work collaboratively, for example, with midwives. A midwifery service is an integral part of our team. They are with us. We are the backup for the midwives, but we all live in the same labor and delivery. They have their clinics. We are their backup if they have any questions, but respecting that they have their role, I have my role, and we all know what our limitations are. We have had experiences, and I think it's in the medical realm, I think delineating those roles is important. It's important to know who the support system is. And so, like Dr. Eko talked about having doulas, I think that's a great resource for patients. But I think it's also important for the patients to also know, what is my medical provision, what is my support provision, and how can those two work in the same realm without being antagonistic to each other. So I think over time, because those lines are not always clear, that's where we get the sometimes the antagonism that comes with it from, well, I'm the doctor, or I'm this. So I think those collaborations and us talking about is important. And the last thing I'll say about collaboration is that's at the very basic, taking care of a one-to-one patient level, but then us now partnering with the other stakeholders who are taking it further. For example, being here to have a conversation with a group who is looking to not just be with these patients, but maybe come to their visits or take them and through their pregnancy and do home visits, and understanding where that fits into my provision of care. I think that's all part of what we have to do. So very valuable.
I think part of it is this, for example, is an excellent start. Hearing the stories and discussing about how, we all can be in our own silo and have an effect locally, being able to connect with one another, being able to kind of create a system here in Harris Health where we are all connected, because, frankly, we do see all the same patients. We have a patient who may go to me and then go to Dr. Leke, and then maybe with Dr. Lani, and so it's important that we are connected in that sense, that we could all work together. I think both the medical and outside of medical is also very important. For example, I work with Dr. Ladani, and we talk about patients. We make plans for them together. And like my nurses are excellent. A lot of them used to be midwives, so they're all focused on having like a vaginal delivery for the patient if possible. And then I think part of it too is I was going to say picking up the phone. Like if I have someone who has a cardiology problem, then I'm going to call the cardiologist. I'm going to talk to them. If they need an ophthalmology visit, then I'm going to call their ophthalmologist and see if I can make an appointment for them. And I want patients to know that we are doing these things. These are things that, sometimes a patient may feel so overwhelmed because they're not able to get these resources themselves. But we are definitely here to help them. One small story that I'll share just in terms of that is I had a patient who actually was a sex trafficking victim who crossed the border, and then she also she ended up with a mass in her back, and she had paralysis.
paralysis of her legs while she was pregnant. And then we ended up getting social work to go help her. A couple of my nurses actually went to her house to help her to physically clean. She had a child, though she wanted was a child to visit. I made sure her child could visit her while she was in the hospital. And then even after she had her second child, we continued to provide support and go out to support her. So, there are plenty of people who are willing to help as well. But, we also need to hear the story. We also need to be aware of what's going on in someone's personal life so that we can help them as much as we can. And if we can physically help them, be able to assist them with other services and connect them with other people who can help them.
So interprofessionally, the first thing that comes to my mind is collaborating with my mental health colleagues. So, having at Hope Clinic, we have counselors, we call it warm handoff. So we have counselors sitting at each station, and if a patient is in need and it's somewhat urgent, we can have them see the counselor right away. And then other social, people to help me with other social aspects, like social workers to help address the things that I talked about earlier, like transportation, rent assistance, food insecurities. We have a program called Food RX, and so currently it's for our gestational diabetics, but we can actually send the patient to a food bank that supplies food more locally. They don't have to go to the food bank, but we have it set up at a local community center, and they can go choose healthy foods. So collaborations with social workers and other professionals that can help me take better care of the patient.
Thank you. The last question, so that we can allow time for the audience to ask questions as well. And we've talked a lot about, and I've heard you say a lot about the services that are offered, and a lot about the behind-the-scenes effort to make sure that the patient gets individualized care. What kinds of things can we do to empower the patient and educate the patient that these services are even available, and that and help them trust that you are an advocate for the patient, and engage the other community supports in that?
For the patients, again, I think it's a little bit easier for me because my patients probably are some of the neediest patients in the county. That's just by virtue of where we are. So my home clinic at MLK, where I see my pregnant patients, actually without the residents, this is like my little private clinic, is probably, even though about 15% of our delivering population is African American, there at MLK, probably about 70% of the patients I see are African American. And so what we try to do from their OB screening visit is they get information about what resources they might need, or if there's a flag. For example, we screen all our patients at the screening visit for depression, if they have postpartum depression in another pregnancy, or if they currently have any symptoms. And if we get that flag, then it's immediate, like, well, what do we do with that flag now? How do I follow up and make sure that in addition to getting the OB service that they need, she has a mental health visit. We're also screening for substance abuse at the screening visit, only again because we know the biggest contributing factors to maternal mortality in our state. And so where I see most of my patients, I think what we try to do from that initial OB screening visit is let them know what resources, use that as a way to say, beyond just you're pregnant and the routine, here's a prenatal vitamin, or you should get one. What are the things that may contribute to your pregnancy that we should be doing differently? And start with the screening there, and the recommendations from there. And sometimes from that screening visit, maybe I'm not the appropriate person. Maybe Dr. Burgess, the MFM, is the appropriate person for that patient to see at the next visit, rather than trying to come to me. And then identifying things like, well, you had your screening visit now at 20 weeks. That's because you didn't have transportation. Should you come now see Dr. Laker just because it's closer, when I know that that one visit that you need is with Dr. Burgess? Maybe that's where we should, take that one gas opportunity that you're going to have and have you see the consultant first. So those kind of that kind of coordination is very much integral to the screening visit. Again, it's harder to do when there are all those other limitations that have made it such that patients cannot get the access and are coming in later. It's harder to then do those modifications, but I think that's one of the main ways to really start to empower the patient about what the other issues with the pregnancy might be and what then are the resources. Because unless we're harping on it, I had a patient who came last week and had an elevated blood pressure noted at an emergency room a few weeks before, went home and she was 30-something weeks pregnant, came and was asymptomatic but with very, very high range blood pressures in the clinic. And so I'm trying to figure out how to get her into the hospital. And I check and the baby has no heart tones. And she had no clue that any of this was going on. And that's primarily because she was aware that her pressure was a little bit elevated 3 weeks before, but she didn't know what that meant for her in her 3rd trimester of pregnancy. And so it's taking the information that's in front and saying, especially when we have the opportunity to do it early enough, and saying, okay, here's what might happen in your pregnancies, here's how we can modify it, and then working together. So it's giving them the information when we have it, and then establishing the relationship that allows them to trust it. And none of those are easy. I'm not saying this is very idealistic, right?
And I'll just piggyback off of that. I think that's the biggest thing in my patient population, is them understanding just because you don't feel anything and you feel fine, if I am sending you to MFM or I'm sending you to pelvic physical therapy or mental health institutions, just because you're fine one day doesn't mean you can be fine the other day. And it's very important to educate them that if we're sending you out, if we're referring you to others, it's very important to do these things, because we're, at the end of the day, we're doing them in your best interest. That's always my biggest hurdle. Or patients who are like, oh, I know the baby's gender, so why do I have to go to my anatomy scan? What could possibly be wrong? Well, a lot could possibly be wrong, and there's no way for us to know unless you get your anatomy scan, unless you see the high-risk OB doctors. So that's always a lot of times the biggest hurdle, is if they feel fine, they think everything is fine, but that's not necessarily always the case. Or, oh, I took my blood pressure medicine one day and now my blood pressures are fine and I take it as needed. No, blood pressure medicine isn't as needed. Anti-diabetic medication isn't as needed. So that's always the biggest thing, is a lot of times they don't want to take medication because, again, the distrust is the medication you're giving me actually what it's meant for. And a lot of times I feel like education and constantly following up with patients, that's the only way for them to really understand and do the things that we need them to do.
Dr. Brown, thank you for this question. I think it's an excellent question, and it's something that I actually spend a lot of time thinking about. One thing that I am very confident of is that when a patient comes to me, I know they're going to get excellent care. My staff is excellent. We work very hard. Their doctors have already done the right thing and are following them and bringing them to a high-risk doctor. But I spend a lot of time being concerned about the community at large. What about the patients I'm not seeing? And that's a big concern of mine. One of the things that I did with my partner recently, he's a hospitalist in a rural area, is because he was so concerned about his patients, he drove around. He drove about 45 minutes out to see where his patients live, because he was so concerned in terms of, what are they experiencing on the outside that they come in with certain illnesses. And so I did the same thing. I work in Southwest. I drove around a bit and I looked at some of the apartment housing and how, people can be very close in contact, and sometimes it's a one-bedroom apartment and there might be 7 or 8 people in there. Sometimes people don't have, some of the things that we discussed in terms of food, like Dr. Leani mentioned, or electricity, or things like that. So, I think a lot about the community partners aspect. That's one of my goals and one of my missions is really the community partners. There's services that we have. There's one that there's a there's a postpartum visit that women may attend, and it's a separate group that the community leaders are leading. And so I'm like, okay, I want to go to that group. I want to talk to these women. And so, my goal is really just to form those connections with people who are already doing the work. And therefore hoping that together we can, have patients routed and coming to the right places so that they'll have that access to care. And then one other thing I do want to mention, as Dr. Brown had mentioned earlier in her stats, African American Black women are 28% more likely to visit the triage. A lot of patients come into my triage. That's like my most exciting time. I'm running over there to see whether she has the access to care, seeing if she is seeing a doctor regularly. If she has no prenatal care, what is going on? How can I get you into my clinic, and how can I link you in? So it's just really trying to figure out different ways in which we can really link together so we can access those people who don't really get to see us regularly as doctors.
So I'd like to echo the importance of education, and it is so important to educate our patients. And I think we can do a better job. Usually our OB visits are really short, so we don't get a whole lot of time to do the education part, but there is technology now, and so something that we've rolled out at Hope Clinic is called Baby Scripts, and it's an app that patients can sign up for, and they get regular reminders and education pieces and tidbits here and there that help them know signs and symptoms to look for that might be alarming, and they need to see call their doctor or go to the hospital. So I think we can do better with technology. We also have it's called remote patient monitoring. And so we have another aspect of technology that we can use better to monitor blood pressures from home. And so things like that, I think we can start taking more advantage of and to help educate our patients.
Thank you so much. We've had some great conversation. I think we're ready to open it up for question. Oh, I'm sorry. We have Congresswoman Sheila Jackson Lee with us. Are we? Yes. So I think we're gonna divert a little bit for just a second.
Yes, we want to take an opportunity to welcome Congresswoman Jackson Lee. We're so grateful for your presence here today. We know that you do so much on behalf of the residents here in Harris County, and your work on the Congressional Black Caucus in advancing issues such as Black maternal mortality and Black infant mortality, prioritizing that work, centering that work, and we're grateful that you're here today. And we'd like to take the opportunity to hear from you to help empower and energize the folks that are here in this room that are going to be doing the work to advance reducing and preventing maternal and infant mortality. So will you all join me in giving a round of applause to Congresswoman Jackson Lee?
So very much. Thank you so very much. Good morning, everyone. It's a pleasure to be with you this morning. Thank you so very much. Delighted to be here. I don't need this. Yeah. Delighted to be here with Commissioner Rodney Ellis. We have been conversing about the importance of this. Thank you to Harris County Public Health. And let me as well acknowledge you for the stupendous work that you did during the pandemic and being on the front lines when Harris County was at its most frightened point. And that was during the peak of 2020 and 2021 when most of our citizens could not imagine that we'd ever raise our head and have COVID somewhat behind us. We know that COVID remains as part of the circumstances of our lives, of our health lives, but we're very grateful for the hard work, the opening of the NRG, the testing, the vaccination. So give yourselves a very big hand. We thank you so very much for your work. I am going to take just a moment, but you've touched my heart, and I'm wearing a T-shirt. This is a family that promotes STEM, but I wanted to show that this is what we'd like to see for all families who are desirous of having children. Happy, healthy children and a happy, healthy birth. And it is somewhat troubling here in America that we find ourselves with no condemnation of third world nations, that our maternal mortality rate, particularly amongst minorities and African Americans, equals to undeveloped nations. That is insufficient, unacceptable, and frankly frightening. And we can't have the experience of birth to be frightening. You are eager to have your birth go to full term, and it should not be a respecter of your economic status. It should not be, tragically, your early nourishment, but we want to correct that. But that's what we're finding. We have seemingly brought down teenage pregnancies to a much lower number than it's been in the past, but we know that that's very difficult as well, and a teenage mother is also susceptible to these kinds of things. So to thank my good friend and to thank you for holding the Black Maternal Health Summit here in Harris County, and to recognize your own strength against and courage and the power that has to help us overcome the vulnerabilities. There are tears, joy, sadness, pleasure, and many more emotions in bringing life into this world. And I applaud all of you for recognizing that in these modern times, a little help is necessary. I'd like to encourage more practical training, so nurse practitioners and others begin to specialize in maternal issues, and so specialize in stopping maternal mortality. Nurse practitioners are really on the front lines and can be the first line of defense along with public health systems. In 2020, 861 women died of maternal causes in the United States. 861 women who planned on living full, healthy lives and planned on being parents to their children, who they carried for 9 long months. That 861 children must grow up without their parents. That's a medical system in society that has failed 861 women. The terrifying part, in the U.S., 2/3 of those pregnancy-related deaths are preventable. And for every pregnancy-related death, there are 70 pregnancy-related near-death experiences. There is a serious and severe gap in care that is contributing to these avoidable casualties. It is extremely important that we remove barriers in health care that may be contributing to these deaths. One of the reasons why we are fighting for, since I've been in Congress for, now I can speak about the history of Congress, almost, but you never stop seeking new ideas and freshness to serve people. And that's what we did with the Affordable Care Act. We tried to get our hands around providing health care for every single American. And we worked darn hard. And as a member of the Judiciary Committee, every one of our committees had a special role. As many of you know, we started out with Medicare for all. And we tried to get a system where everyone could have through Medicare for all. In that not working, we still kept plodding on until under President Obama we were able to design legislation, and what we did was the public option. We expanded Medicaid. But unfortunately, with the other side, as I try to be polite, it was an opt-in. And that meant that states like Texas and some of the southern states, but our Louisiana friends opted in. And they basically have got health insurance for all Louisianans. Here we are still the poster child in Texas for having the most uninsured persons. That has a devastating effect on pregnancy and then to birth, diabetes, and that's another thing. They're the overlapping conditions, pre-existing conditions that our mothers-to-be will have that may draw upon their strength and cause there to be some concern. So we're now fighting again to ensure that we can get, if I might say, leadership that would opt in. $100 million every year that we are losing. We've lost it for 10 years, now 12 years, because the Affordable Care Act was in 2010. And I can assure you that you go up to somebody now and say, well, let me take that health insurance that you have away. Weren't you one of those that said you didn't want Obamacare? And I think you would be in an altercation because people have gotten used to having their health care. The mothers need to get used to it. They need to be able to rely upon it, particularly those mothers who are overweight, as I said, diabetes, pre-existing childhood diseases. We need to make sure that that is one of the constitutional privileges by way of accepting the fact that we have the right to due process, we have the right to equal protection under law. That's all in the Constitution. And it opens up by saying we have ordered ourselves to create a more perfect union. There's a severe gap in care that is contributing to these avoidable casualties, and it's extremely important that we remove barriers in health care that may be contributing to these deaths. In comparison to other industrialized nations, the United States has been trending downward when it comes to maternal health, and numbers continue to get worse. According to the World Health Organization, from 1990 to 2015, maternal mortality rates increased by 16.7% in the United States. In the rest of the world, maternal mortality decreased during that same time. The United States is getting progressively worse when the opportunity to improve is right at our fingertips. And I do want to applaud my colleagues, my fellow women members of Congress, that we organized the Black Maternal Mortality Caucus. And many of you know the names that have been engaged, and we have been able to carry legislation that has been passed dealing with maternal mortality. You should be getting funds directed to that. The MAMA Act, all of this legislation should be what you should be able to utilize locally for resources. According to the AMA, black women are 3 to 4 times more likely to die from pregnancy and childbirth than white women. Black women across all socioeconomic statuses and education levels are more likely to experience maternal mortality than white women. So one of the things that we need to do in the federal government is actual finite research. We've got to find out, is it DNA? What characteristic is it? Because you just heard me say, it does impact poor women, but it impacts women of all economic backgrounds. We must pierce into, there must be direct research. So one of the things that I've done is I use the Pentagon, the defense bill. And so I've used the defense bill for triple negative breast cancer, $10 million every year for research about triple negative breast cancer. Why does it impact women of color more devastatingly? And of course, it metastasizes, but triple negative breast cancer has a higher mortality rate. So in this instance, women are in the United States military. That is the nexus. And I think it is important for them to begin research on the issue of maternal mortality, particularly as it relates to black women. We have seen many stories of this exact problem. Hulu's documentary titled Aftershock shows the journey that everyday families endure after losing a mother to childbirth. Serena Williams went through a traumatizing birth experience where she had to advocate for herself because medical professionals were not listening to her concerns, and she felt that she was dying. There are countless women and countless stories that are not told. Why are black women experiencing such poor health outcomes as relates to childbirth? One of the things that I hope that will come out of this is black women speaking up for themselves and medical professionals being sensitive to what they're saying. Pain, shortness of breath, all of this should be a part of the work. Let me just continue and finish. According to the data, there's a lack of preventative care being shown to the black community. When pregnant black women do seek care, their concerns are often dismissed. One of the issues is the level of insurance. And so in public health, I hope as you see pregnant women in your clinics, that there will be sort of a model of what you listen to, what you hear for, in addition to the examination. Barriers of access, cost of treatment, structural racism are just a few of the reasons that black women experience poor health outcomes. These numbers are heartbreaking. With all the advances in technology improvements in our healthcare system, health outcomes continuously worsen for women. The regressive reproductive laws have been codified since the Dobbs decision only heightened this disastrous outcome. The question is, what can we do? How do we make sure that more women are alive to see their babies grow up in a time where women are being forced into giving birth? How can we make sure that they aren't also dying as a result? And I think the point that I want to make there, health care should be your personal decision. And I've heard people say when the government gets into the doctor's examining room or the nurse's examining room, or the decision between loved ones, or your faith, then you may have a mixture for disaster. We must ensure that there is good health access, both to that pregnant mother and to that mother who has the good fortune to have some little ones afterwards. Pediatric care. I'm getting ready to call one of our infectious disease doctors to ask, I want to get the acronym right about RSV, because we've been quiet, and it is noted across the nation that hospitals are filling up with children on RSV. That might be their COVID of 2022, and we need to be aware of that as well. So every moment of health care we should be providing. I also want to call on medical professionals, healthcare systems, and legislators. As I said, I intend to seek more research to give us the roadmap. Why is that there is an increase in black maternal mortality or in any aspect of mortality? Call on families to be sensitive to their pregnant moms or pregnant sisters or pregnant daughters, to be able to be helpful to them. Be very attentive to the facts of what is going on in her life as she is continuing her pregnancy. And we must protect the lives of pregnant women. And so I supported legislation, COVID-19 Safe Birthing Act. I co-sponsored the Kira Johnson Act, which would work to end preventable maternal mortality and severe maternal morbidity in our nation. I offered an amendment that requires a report on the rate of maternal mortality among members of the armed forces. So I'm beginning to work my way up to have one of the largest budgets in our overall budget to really focus in and do research. I joined two of my colleagues, Congresswoman Alma Adams and Lauren Underwood, who launched the Black Maternal Health Caucus to address maternal mortality in the United States. This is not a choice, it is a mandate. It is a mandate that we seek to save lives. It is a mandate that we give joy to those who seek to give and have a healthy birth. And you are pointedly at the right place at the right time. I thank all the panelists who I know have probably more than I have been able to do, pointedly talked about what is necessary in this fight. It is a fight, by the way. And I encourage you to fight for this expanded Medicaid. That's policy, that's not politics. Whoever's elected, obviously, I'm going to say it, I'm supporting Beto O'Rourke, who has made the commitment on expanded Medicaid. And I'm going to be positive. But we have allowed past administrations to just sit by and ignore the needs of this state and not take the expanded Medicaid. That's your tax dollars. That's health care. That's not politics. It's health care. And you can imagine our frustration. And every year, those of you in the health professionals know about 1115 waiver. We were on the brink. Texas Children's Hospital had a $80 to $100 million backlog bill on Medicaid children. They were still serving them. Other hospitals were about to close. I had to negotiate the 1115 waiver with the administration because time after time they had given us a waiver. And of course, Texas sued us. And there was a decision whether or not we were going to, as a federal government, let the lawsuit go on until Texas take a hike. But the hospitals were on the verge, and so in working with the president in particular to get them to settle the case so that your dollars could have come just about a couple of months ago. Every year we face that because we build up a Medicaid bill and we don't have a structure to utilize Medicaid. So we're into Medicaid, if I may use a terminology that is not appropriate, sucking Medicaid, but we don't have a structure. And we're losing to California and New York because we are 29 million people plus with the highest number of uninsured. It's health care. It's not politics. It's people over politics. It's policy. And so I encourage you to be advocates for expanding that Medicaid. Speaking to the health officials in Austin, I talk to them all the time. I know what they want. They want to have the expanded Medicaid, the health professionals in Austin. And that's who you should be advocating with. And even the county judge here and beyond we tried to get expanded Medicaid to go just to the counties. Who wanted it? They could opt in. But in the federal system, everything has to come to the state. So if I leave you with anything, it is listening to all of this, but acting on all of this. Because listening educates, but acting saves lives. And so I hope that this will be an opportunity for there to be an expanded body politic of individuals who are well informed, who will get into a letter writing, get on a bus with 50 people, and bang up on this state to be able to opt in, because our good friends at the county, who are one of the best as relates to Harris Health, public health, want to give as much funding as possible. If we had not been at that point, we would have had even a more disastrous circumstances on COVID, and COVID is here to stay, and the flu season is coming. Get your flu shot, by the way. I hope you all have some massive flu shot locations, because infectious diseases are now part of the world because we're so small. And I end on this note. I just came back from Pakistan a couple of weeks ago. Massive, massive biblical flooding. I know we had Katrina and we had Harvey, but I tell you, they exceeded that. It was an ocean. 33 million people affected. 70,000 women are about to have birth in places where there is no medical care because they're surrounded by water. And waterborne diseases are on the rise because the water is still there. They have no drainage. I say that to say is because infectious diseases start up, but the world is small. And so we don't have time to not get the expanded Medicaid, and we don't have time to continue to watch women suffer and die in childbirth. So this is a call to action to save lives. I thank you for the work that you've done. I need a few soldiers on the battlefield that are not going to stop until victory is won. More lives saved, more children born, and more people provided health care, not only in this nation, but right here in Houston, Harris County, and this great state of Texas. Thank you all so very much. God bless all of you. God bless the United States of America. Yes. You want to come on up so I can present you with this acknowledgement for your work. If you help put this on, run on down here quick. If you don't run on quick, I'm running out of here quick. If you don't move quickly, there's a gentleman that knows what he's supposed to do. He's moving. He's moving. All right. Is somebody else moving? Thank you. Anybody else? Anybody else? Yeah, I mean, that's what I'm saying. Come on. You're all in the wrong spot. Yeah. Come on up. Yeah, my goodness. It's like the church. Come on down. Come on. Move up, guys. Move up. Dante? Oh, my gosh. Wow. These people are afraid you're going to ask them for offering. And so that's why they're not coming. I'm giving you money, my friend. I'm not going to ask you for anything. Harris County Public Health Black Maternal Health Summit. We're excited. And on behalf of the constituents of the 18th Congressional District, we thank all the county commissioners, in particular our good friends Judge Lena Hidalgo, Adrian Garcia, and as well Commissioner Ellis. And we thank our other commissioners as we look forward to the budget being passed as soon as possible. But let me acknowledge this on the occasion of our Black Maternal Health Summit, your commitment to increasing the number of healthy families in our community by providing high-quality, comprehensive health services reflects the pride that exemplifies the spirit of Houston. You're deserving of the commendation, respect, and admiration of the United States Congress. Sheila Jackson Lee, Member of Congress, on this day, the 22nd.
Please give another round of applause to Congresswoman Sheila Jackson Lee. We're so grateful for your advocacy, all the work that you've done and that you'll continue to do on behalf of the residents of Harris County. We so appreciate you, and I'm actually going to go out with you because we do need some advocacy. Harris County received no maternal, child, and adolescent health funding from the state of Texas, and so we really could utilize. Yes. So that advocacy work, right, it's a call to action. That's why we're here today, but we need your leadership. Yes. Yes, it is. Okay, yes. Yes, I'm that's why I'm following you.
You didn't call me. That's unacceptable. Yes. All right.
We applied for 7 million, just so you know.
Yes.
How much was, I'm sorry.
7 million. And Harris County has the highest black infant mortality. Harris County, Wayne County, and Detroit area, Cook County, and we account for 10% of black infant mortality and receive no funding. And so our request is that the federal HRSA administration actually put in stipulation that says you have to give funding to those jurisdictions on the disproportionate impact. Okay.
Right now, the state, and so the first round, that round is gone?
Yes.
With no resources there?
Yes.
So then I have to fight now, because that is absolutely absurd. Y'all are too quiet.
We just found out not that long ago, so we're galvanizing.
And you had submitted a request?
We did, and then requested an answer. So
Right?
thank you
And then
all.
1, 2, 3, I want to, no. 1, 2, 3?
No.
I can't hear you.
No.
I can't hear you again.
No.
All right. Thank you all.
All right. Again, thank you so much to Congresswoman Sheila Jackson Lee for speaking with us today. And I do want to, again, thank our panelists. We didn't get time to really get into additional questions. We may try to, I think my moderator went out, so I don't want to go out of turn. And I don't have my glasses on. I got to wrap up. I'm sorry. I did see that. All right. Again, I think our panelists may be with us for a little bit, at least I hope, through lunch. So if you do have questions, certainly can reach out to them. I think we are ready to serve lunch, and then also have another speaker during lunch. So I don't know. Okay, we're ready to serve lunch. So again, thank you so much to our panelists for being with us today and speaking with us. And lunch is served.
Yes, we did.
Okay, so we are going to begin our lunch discussion. The lunch talk would be investing in social determinants of health to improve maternal health outcomes with Ms. Jessica Pugel. Thank you.
Good afternoon, everybody. Thank you so much for inviting me to be here. I'm super excited to be here. This is an issue that we've been doing a lot of work on for the past 5 or 6 years, and I have a big passion for it. There's a lot of work to be done, but I'm encouraged by the great work that's being done here. So my name is Jessica Pugel, and I am with an organization called Working Partner. We do strategy and evaluation work and have for the past 5 or 6 years led an initiative called Improving Maternal Health in Harris County on the part of Houston Endowment. And the material that I'm going to share today is a lot of what we've learned over the past 5 or 6 years working in this particular area. So I'm going to do this. Yep. I want to say how excited I am that Harris County Public Health is taking on this issue. It's weird. There's not really a lot of places, not of organizations who have just maternal health or claim maternal health as an area of effort. And so for a long time, it's been hard to figure out if somebody wants to lead this work, who can do that, right? And it's so exciting for Harris County Public Health to do this, partly because we know that there are medical implications to this, but this is not a medical issue exclusively. There, as Dr. Brown kind of alluded to, and as we heard through this, there are so many other issues that are driving maternal mortality, and that's what I want to talk about. I think it's wonderful about all the investments that are being made. So we heard this esteemed panel of physicians that were up here, and a lot of them are talking about, we know that people in hospitals and other doctors know that this is an issue, and they're really doing a lot to address this issue. And in particular, the state has invested in a couple kinds of things. There's something called maternal levels of care, These are hospital designations that have been given, and given the designation of hospital determines sort of if a woman's high risk, she probably doesn't want to deliver at a level 1 hospital. She'll want to go to a level 3 or level 4. That means those hospitals that are level 3 and level 4 are able to handle far more complex kinds of cases. So there's these efforts within the state to kind of do that. And then, of course, there's been the AIM bundles that have been sponsored by the state that are led by the Texas Mothers and Children and Mothers Collaborative statewide, who are doing things to implement best practices within hospitals to improve things. So that's really good. But, you know, I'm going to go out on a limb here, and I'm going to argue that maybe if the state's going to invest money, these are maybe not the most important areas to invest in. Partly because hospitals are on it. Look, you had, I think every single woman who is here, this physician up here, is amazing. They know these issues. They're trying to address them all the time within the hospitals, but there just isn't that much attention being paid to the other social determinant of health issues that are driving maternal mortality. And so that's what I'm going to talk to you about today. Now, one of the things I want to say is a lot of times when we think about social determinants of health, we think of specific things. We think of housing. We think of transportation issues. We think of food security. Frankly, there has not been that much research done on the correlation between those social determinants of health and maternal health. I read a meta-analysis that was recently done of 83 studies that looked specifically at the implications of social determinants of health and maternal mortality, and there's not much there. You know, the two big correlations are racial bias, which we're going to talk a lot about today, and I know Alicia Lee's going to come up and talk about implicit bias after this, which will be important and exciting, and health insurance, access to health that we've talked about. But from our own experience and from some other work that people have done, we know that there's other things there. So on this particular chart that I want you to pay attention to look at is, this was we have a state task force, a maternal mortality task force at the level of the state, who goes through cases every year. They're supposed to do an annual review and study what is contributing to maternal mortality in the state of Texas. And this particular information comes from their 2020 report, right, where they looked at what are some of the things that are driving maternal mortality in Texas, right? And so the things that they looked at are patient and family. These are things that our panel just talked about, so it's not going to be a surprise. Lack of knowledge about the importance of the event or how to do treatment or how to do follow-up. Right? Delay or failure to seek care. Lack of access or financial services, not adhering to medical recommendations. We hear about provider and facilities, right? Those are things that we already are spending so much time investing in. But then there's systems of care. Let's look at the lack of referral or consultations. Maternal health is very fragmented. You know, if a woman wants to go get a pap smear, maybe she's not going to be able to get it at a regular doctor. She's got to go to a completely different doctor. She's got to go to an OB-GYN, right? And so our prenatal care, our reproductive care, our contraceptive care is very much separated from our general health care, which creates even more challenges in accessing the kind of quality of care that we need. And then there's community issues that are driving it, right? Lack of knowledge about the importance of it, chronic disease, violence and intimate partner violence. There's so many other issues. And so handling this, and again, I'm going to go back to why it's so great that Harris County Public Health is leading this, is because we really need a multi-pronged approach. It's not just about a medical approach. It's not just about, other kinds of issues. It's really trying to do all sorts of things together. So these are the sort of what we see is, from our experience, the four big things that are affecting it. And I want to talk to you about these four things: the access to care and health insurance, behavioral health, bias around race, gender, income, and domestic violence. So we think these are four big bucket areas that are driving it in Harris County. And I want to talk a little bit about each one of those. So, oops, did I bund? Okay, so now... Yes. Okay, so limited access to health care. I think we've already heard a lot about it already, so I don't need to replicate this information to you. But, you know, in Texas, if you're over the age 18 and you can't afford private insurance, you're not going to get any health insurance. Medicaid is really only for kids under the age of 18. The only exceptions there is if you're pregnant, or if you have some sort of a disability. So if you are low income and don't have private insurance, the only time you're going to get health insurance is if you're pregnant. But all that health care, so if you're not taking care of your health or you have other kinds of health issues, these things accumulate over time. So if you get pregnant and finally get on to health insurance, you may have health conditions already at play that can put your pregnancy into risk. So in 2015, 22% of women had at least one condition that put them at high risk for severe maternal morbidity, right? And so we know if you are unhealthy going into your pregnancy, it's not likely that you're going to be able to get healthier during your pregnancy to do it. And I think one of our physicians talked about, you know, you get a woman who comes in at 35 weeks and she's got some other health issues going on. You're not going to be able to address those. And so that puts her pregnancy at risk, right? So now let's say that you're a low-income woman and you are pregnant, and so you're going to get onto Medicaid. This is the nightmare that you get to encounter. We call this a spaghetti map of, this is basically a decision tree of all the decisions, the decision points that go to in terms of do you qualify for Medicaid. So up at the top, if she's in and she qualifies, is she a U.S. citizen? You know, yes, then you have to say, are you pregnant? Yes, and then if you're pregnant, you have to have an income that's lower 198% of the federal poverty line. That is not very much money, right? But what's interesting too is, let's say, no, and you are pregnant, you can get another type of Medicaid, but then the income level is different there, right? So this is a mess. It's a mess. It's extremely hard to navigate, right? And there's a lot of different decision points and not everybody's treated the same. And then on top of that, the application is time limited. So if you don't get your paperwork in within 6 weeks or something like that of applying, guess what? You got to start all over again. They kick your paperwork out and you got to start over. So this is hard work. If you're a woman, you got a job, maybe you have other kids, and doing a whole bunch of paperwork and getting it in these time frames can be a real challenge, which forces a lot of women to lose their access to health care. So they just give up. All right, so that is another barrier, right? And then again, this fragmentation of reproductive care. You know, you have a general physician, but maybe you got to go to somebody else for your contraceptive care, and then you want to go to somebody else for your pregnancy. And so these kinds of things basically decrease access. It just makes it so much harder to access health care. Information is harder to get by, and all of those things compound to have a negative impact on your pregnancy. So now I want to talk about some of these issues are so insidious and so difficult and so huge. And I want to talk about healthcare financing, okay? Because financing has so much to do with how you get treated by a physician. So generally when you get an appointment for the doctor, you're going to go in for a 15-minute visit, right? So 15 minutes, let's just say you're busy at work, you got to take time off, you got to drive to the doctor's office, you got to wait for the doctor, and then the doctor comes in and gives you 15 minutes of time. A lot of times that's not enough time for questions. That's not enough time to... So for a lot of women, this is a lot of work for a little 15-minute window. But guess what? If you're on Medicaid, the doctor can spend 7 minutes with you. 7 minutes, right? Now, I'm not trying to vilify doctors. This truly isn't. I'm sure doctors would love to spend more time, but the pressures of financing are so great, right? And what happens is it has this cumulative kind of effect. A woman goes in there, she gets 7 minutes with the doctor, she doesn't get any of her questions answered sometimes, and then if the doctor's rude or asks questions or has a lot of judgments about how many babies she's already got, do you want to spend more time taking time off of work to go see him? So a lot of the things that we heard up here about those physicians who said women aren't coming in, sometimes very rationally are women like, why? Why do I want to go through so much trouble to have so little time, not have my questions answered, and sometimes have a doctor just be out and out rude to me? Right? So in part of the work that we did, we were extremely happy to have opportunities to do focus groups with women and really kind of understand what is their experience getting care. And, we know that almost everybody who was an African American or a brown woman had much more worse experiences than white people. I'm sorry, it's not doing what I needed to do. But we heard it. Like you go into the doctor's office and the doctor has, now doctors have to type all their notes into an electronic system. So they're sitting there the doctors are doing what they have to do, but the taking the notes makes it hard for them to connect with you and to talk to you and ask your questions. And then a woman's like, well, that person doesn't care about me. We heard somebody on our physician panel talking about mental health. Mental health was the second most significant driver of maternal deaths in the last review by the Texas Mortality Review Commission. Mental health, right? And so a lot of times women will go into their doctors. These doctors are OB-GYNs. They don't know about mental health. If they don't have referrals to do, how do you handle that, right? So a lot of women feel like the doctors just shut down when they want to talk about some of the issues that they're facing with. So all of these things then together go bundle up and become cumulative to the point that a lot of women just don't think it's worth it going to the doctor. And this is why we can have women coming into a physician at 36 weeks not having received any prenatal care because, and now it's time to deliver. So really there's these cultures and other kinds of things that really have a lot of effect on it. Now, one of the physician groups that we heard, physicians here talked about the role of stress. And stress is real. So we know for Black women and their families, the stress of just living through prejudice and inequality is huge, right? But then there are so many other stresses on a day-to-day basis that women experience that then has a negative impact on their pregnancy. So anxiety and worry, maybe how you're going to pay the bills, how you're going to, your money is tight these days, inflation's high, you got a lot of worries. Maybe you have an unhealthy relationship that's causing difficult. I'm going to talk a lot about domestic violence in a minute, but one of the things that we learned is, women encounter so much judgment from people during their pregnancy. Maybe their friend doesn't like the man who is the father. Maybe the woman thinks that she shouldn't be doing it now. These are your close friends who you need support from. And when you have so much pushback from those people, it can create a lot of stress and anxiety around your pregnancy, right? The ability to get insurance coverage. Maybe someone's been incarcerated and that has something to do with it. There are just so many stresses that women can experience on the day-to-day lives that has an impact on how well they're able to take care of themselves and the impact on their violence, on their pregnancy. So now I really want to talk a lot. This is an issue that I think is very, very upsetting, is about domestic violence and substance abuse. So just to indicate for you how much we treat this issue as a medical issue is the definition of maternal mortality, right? So a lot of times the definition of maternal mortality and how it's counted is counted at the time of delivery or a hospitalization postpartum, right? So all of the data that we have right now that we're using to understand maternal mortality is healthcare data that comes out of the hospital, right? And so something that I only learned just last year is if a pregnant woman comes in and has been badly beaten by a partner, she goes into the emergency room, and let's just say she dies, but if she doesn't make it to the labor and delivery, her death will not be classified as a maternal death due to domestic violence. When I was looking at the meta-analysis of social determinants of health, a lot of the people who are examining social determinants of health are specifically taking out homicides and suicides out of their cases because they think it doesn't align with the definition, right? But we know that there is a ton of death and severe mortalities happening in the area of domestic violence, right? This is I want to argue that this is a serious, very difficult problem, and it's very frustrating to me that nobody's talking about the role of domestic violence when it comes to maternal death and severe morbidities. And, you know, I've talked to people who do domestic violence, and there's no one's counting this information, and they're not counting it because they're concerned about the privacy and the safety of the victims. But if we don't have data that makes the case for how bad this is, we can't solve that problem. So I would argue, Dr. Brown showed us the data about the incidence of maternal mortality. I would argue those numbers are many times higher because we are not collecting data around domestic violence. There's a lot of suicides. I've had the great pleasure of working with some physicians, some OB-GYNs on a project, and a physician was telling me he was at the hospital and a woman was in the waiting room. She was pregnant and she was throwing her body against the wall because she was trying to abort. She didn't want to be pregnant. She was trying to abort the baby. And women are doing violence to themselves if there is some reason they don't want the baby and they don't feel like they have a way of getting rid of it. This is and especially somebody mentioned the post-Roe, now that abortions are going to be even harder to get and that kind of care is going to be harder, I just can only see our numbers getting worse. This is going to be a much more serious problem, and it'll be worse than it needs to be if we don't actually recognize that this is a component of the maternal mortality and severe morbidity landscape, and we don't try to do something else about it. Now, the last thing I want to talk about is mental health and substance use. And again, the Texas Maternal Mortality and Review Committee found in the most recent review that they did that mental disorders was tied with cardiovascular issues on the causes of maternal mortality. And sometimes that involves substance use. So I do think there's so many myths and scary information. A lot of times women believe that if for some reason they're a substance use provider, they think that if they deliver at the hospital, the CPS is going to be outside that door and that baby's going to be whisked away from them the minute it's born. That doesn't have to be the scenario. But when myths like that happen, it creates a disincentive for women to receive care. And so then that just compounds the issues, right? So we really, really, really need to spend a lot more time in these two areas to really understand the connection and begin to see how we can address those issues. Now, the last thing that, again, I'm pretty passionate about this topic, and it's a very nuanced situation. But the reality is, in the culture in the United States, that the minute a baby is born, the woman just disappears. All eyes are on the baby, right? It's all about the baby. And so what happens is we sometimes lose eyes on the women. So someone once told me this when I was learning about Medicaid. Our Medicaid system, women get it only because of the baby, right? They're not getting health care. If you're an adult and you're not pregnant, you're not good for health care. But if you're pregnant, all of a sudden the baby gets it. And then you lose that, like on CHIP for immigrant women, you lose that health insurance literally the minute the baby's born. Our entire system is designed around the babies and not the women. Women are losing sight. In our particular work, we actually won't even talk about infant health. I think it's important to include. I'm not being critical. But the thing is if we don't maintain all eyes on the women, we will never be able to address this problem because it's so easy to talk about the babies. The babies are sexy because there's more money there. The babies are there because it's a great story, We really need to keep all eyes on women. So this is a phrase we when we did our interviews with women, about generally 75% of them feel like they have the kind of supports, but fully 1/4 of those women feel like they don't have any support when they come home. They don't have somebody to help to cook. They don't have someone to talk about their problems with. These things then contribute to those deaths that happen postpartum, right? These are so important. And as women, we're so strong, we don't think to take care of ourselves. We kind of buy into that story that we're not as important as the baby, right? At the end of the day, it has to be about the women, and we have to support them. It's this weird cultural thing that's going to be hard to address, but we got to start having conversations about it. So I want to talk about how we can do that. And there's been a lot of conversation about, education, and education is important. But when we hear of stories of women that didn't die, right? In the cases when we've heard about women who've had difficult pregnancies and they didn't die, it's because somebody was in the delivery room with them, paying attention and demanding care and demanding attention. We all, every single one of us, if we have a woman in our lives that we care about who's pregnant or has a small baby, we all can play a really important role in making sure that she has a healthy outcome. And I want to talk about this tool right here, this postpartum warning signs. This is a tool that was created by AWOM. They are OB-GYN nurses, right? So when how many women in here have had a baby? Okay, so a lot of you. Do any of you remember what they told you when the hospital was dismissing you from the hospital? Right? And what they do give you is literally a plastic bag of reams of paper, which, by the way, if you look at it, doesn't say anything about what you need to do to take care of your health. Right? So I want to, and if you want, I will send it to Dr. Brown and ask you to do that and give it to everybody and put it on your refrigerator, have everybody in the family know what it is and pay attention to it, because there is so much that we can do to make sure that the woman in our life is having a safe pregnancy, a safe delivery, and a safe postpartum situation. We all have, it's more than that, Congresswoman Sheila Jackson-Reed, it's more than education, it's about action. And there is so much action that each one of us can take to let women know that they need to go to the doctor for their prenatal care. Have somebody with her in the delivery room, watching out and making sure that everything's okay and that she's getting what she's need. And then when she gets home, helping her out to support so that she has time to herself, or that she's making sure that she's being well taken care of. So that's the end of my story. I appreciate you listening to me. Thank you.
Thank you so much, Jessica. Thank you. And thank you for all of the work that you do. So we will be taking a 5-minute break. Someone will come around to pick up your plates, and I will be back shortly. For waiting so patiently. So our next segment will be on the impact of implicit bias. And so I would like to welcome our next speaker, Alicia Lee.
Hi, everyone. Okay. Can y'all hear me still? Perfect. Okay. So hi, my name's Alicia. I'm with March of Dimes. I serve as our Director of Maternal Child Health Collective Impact, and I facilitate a community collaborative here in Houston, Harris County, on how do we improve maternal and infant health outcomes as collaboratively together, very much what we are doing here today. And so today I'm going to talk to you, as Michelle said, about the impact of implicit bias and the contribution to racial disparities and inequities that's perpetuating those inequitable Black maternal health outcomes that we see here in Houston and Harris County. And And so I say I recognize as a Asian American cisgender woman, I will never ever experience any of the same biases that our Black birthing women face. However, what I do know is that it's going to take all of us together collectively in order to improve our maternal and infant health outcomes, and I'm using the voice that I have been given in order to do so. So, this picture, what do y'all see? We're also going to be interactive, you know, wake up from lunch. What do you see? What do you see? Okay, so who said they saw an old woman? Okay, now who saw the young woman? Right. Okay. Anyone see both? Okay. So can you? The old woman. The chin is looking down. She has a shawl and like a black coat. Okay. Yes. Yes. Okay. And then the young woman. She's like looking over her shoulder. She's got a little feather in her hair. She's got like a black pashmina, as I call it. Yeah. You can see that. Okay. So. What is our brain doing? What's going on? Why can we see both? And I guess, is there someone who can't see both? Yeah, right. And it's okay. I mean, it's taken me a while. I now know this picture well. But yeah, right, like left eye, right brain, left brain. I'll let you stare at it. I can give you the reference. This is actually, it's a famous painting. It's in the public domain now, Library of Congress. And this is the actual picture, the painting or the sketch. There's a black and white image also that's more like iconic, iconography vector, meaning that you can sometimes see potentially a little bit better, but I like to go to the source of the work. Given the work that I do, I'm like, let me go to actually what's the thing out there. Okay. So your brain, it is computing approximately 11 million pieces of information at one time. But we know that we can't actually compute that many pieces of information at one time. You're probably only processing about 40 of those pieces at that one time. And so those associations that you make, they come from various different things out there. It comes from your life, from your experiences, from what society has told you what's good, what's bad, what's moral, what's just. It comes from your family, your friends, your colleagues, your coworkers, the news that you watch, the news that you read, the social media, everything that bombards you, you know, as you're just kind of scrolling along and you think nothing of it. Yeah, that's all contributing to what is going on in your brain and those quick associations that you are trying to make. So, Merriam-Webster, had to get real technical here of what is the definition of implicit bias? According to my friends at Merriam-Webster, implicit bias is a bias or a prejudice that's present, but it's not consciously held or recognized. So this is not a conscious decision that you are making. It's all of those, again, pieces that you have put together and you formed and you're making those quick decisions for yourself. Another definition coming from the Perception Institute, it says that implicit bias is when you have attitudes towards people or associate stereotypes with them without our conscious knowledge. Again, it's that unconsciousness that we are bringing. So let me tell you a story. So there's a father and a son. They're in a car accident. The father dies on scene, and the son is taken to the hospital. At the hospital, the surgeon looks at the boy and says, "I cannot operate on this patient. This is my son." What comes to mind? Go ahead. Same race? I heard the answer over here. Someone else want to hazard a guess? Yes, the surgeon is his mother. Yes, but who, did you immediately go to the surgeon's the mother? Probably not. I didn't when I first heard this. I was like, it's a gay couple, so they're both males? I don't know. But our perception, our world says, for the most part, we're getting better now, but it says that surgeons are males. And there's also some deceptiveness in this, and that I've told you, a father, a son. I've used that male language, that dominant language. But yes, most of us, because of our perspectives, have said, oh, wait, how can this be? I need a little bit more time to think about it consciously of what's going on. So next, stereotypes. So these are things that are widely held. They're fixed and they're oversimplified because we want to make those quick associations. And it's for that particular person or that thing. And so this slide comes from a great woman who is an OBGYN, and she did this originally for me in a presentation. But there are stereotypes out in the OBGYN world about women, about races, about pregnancy. What are some that you've heard? Yes, ma'am.
What stands out for me is that it shows that she's married. And so often we don't, once we have an implicit bias that a woman of Melanodominant descent would not be a married woman having a child.
Okay, so for those who couldn't hear, she said the stereotype is that if you're pregnant, you're married, which isn't necessarily true. Anyone else? What are some other stereotypes? Michelle, you're shaking, you're nodding.
Well, that a positive pregnancy is something that's wanted and that you're happy about it.
So she said a positive pregnancy is wanted. So in Texas, approximately 50% of pregnancies are unplanned. Doesn't mean that they're not wanted, but they're not consciously planned in decision-making processes for various reasons. Anyone else? Some racial stereotypes about women? Yes, ma'am, in the back.
Unfortunately, what you can sometimes hear from that world is you'll hear that Black women are dramatic, that they will be more drug-seeking, that they will overstate what's going on just to get attention. Yeah.
So she said Black women can be couched as dramatic. They are seeking attention, that they're really, that's not what's happening to them. So here's a few stereotypes for y'all. Anyone? Sorry. Oh, yes.
I would just say the inverse, that the stereotype of Black women all being low income.
Yeah. So she just said Black women are all low income.
Oh, and the other thing is that we can endure more pain.
Yes, and that black individuals can deal with more pain, which we know is there's no correlation of pain and skin color. So these are some stereotypes that are out there. So Black women don't breastfeed. Hispanic women, they don't want their babies circumcised. Hispanic women will labor really quickly. So, just don't even worry about giving them pain medication. Medicaid populations is all Black. That's a stereotype out there. Medicaid patients are non-compliant. Everyone loves the non-compliant word? Yes. Medicaid patients are uneducated and they're poor. And then white patients, of course, they're all compliant and they all care about their health. No one else does. Right. Okay. And so these notions, it's the stereotypes that we've heard, it's the language we've heard, it's the perception we've heard from, again, television, the world, colleagues, textbooks even have said some of these things that we know none of these are 100% true. So today, I believe Dr. Brown talked to you a little bit about the statistics that we have about maternal mortality, maternal death, maternal morbidities, and these are some infant outcomes as well. We know that there is a higher chance of poor maternal and infant health outcomes based upon your race and your gender, your race and your ethnicity. We hear the latest statistics say that about 18 women out of 100,000 live births, they will die as a result of pregnancy or pregnancy-related complications. When we disaggregate that data by race and ethnicity, Black women, it's about 3 times higher. It's about 55 Black women out of 100,000 live births will die from pregnancy and pregnancy-related complications. That's a national statistic. For preterm birth, which we use preterm birth because I say preterm birth is very defined. It is when a woman gives birth 37 weeks or earlier. It is everyone accepts that notion. Fortunately, we have a lot of data on preterm birth, and therefore, for the most part, none of that data is suppressed. Meaning, we can actually show the data. We can show what is happening in Harris County. We can show that up to the zip code level, essentially, of what's going on with our preterm births. So this is a statistic for Harris County. So in Harris County, a Black woman is 1.5 times more likely to have a preterm birth than a white woman. We have, in Harris County, about 1 in 9 babies is born premature. But if you're a Black woman, you are 1 in 8 of those babies is most likely to be born premature. And then when we look at infant mortality, so infant death up to 1 year, in Harris County, we see that a Black baby is 3 times more likely to not see their first birthday than a white baby. And these are stark disparities, and so glad that Harris County Public Health is saying we have to do something about this, and we have to look at our population that is the most disparate, and we have to work with them because we have to focus our time and energy on them. And so each of these statistics, so this is just a statistic, but behind each of these data points, there's a woman, there's a family, there's a child. And so I would like to play for you this story. Nope. Can y'all in the back hit play, please?
I am Dr. Erica Giwa. I have been practicing obstetrics and gynecology in the Houston area for a little over a decade now. I became connected with the March of Dimes working in that model, and more deeply connected on a personal level when they actually reached out to our practice to have someone do a grand rounds on low-dose aspirin. During that presentation, I talked about my preterm delivery. I got pregnant for the first time. I was 35 years old. I can remember talking to my friend saying, I'm going to deliver at 37 weeks. I already know my blood pressure is going to be higher, and that's just what I anticipated. Throughout the first trimester, my blood pressure was fine. As I entered into the second trimester, approaching third trimester, maybe 24 weeks, my blood pressure started to get higher. I was actually seeing patients one day and I started to feel dizzy. So I asked my nurse to take my blood pressure and it was elevated. At this point I was 30 weeks, so I knew I had to go to the hospital. I knew it was worsening. And I just remember crying. I was sitting there and I was just crying. I think I was scared. I think I kind of knew what was going to happen. So actually one of my nurses drove me to the hospital and I was admitted. They changed up the medications and I was spilling a lot of protein in my urine, several grams of protein in my urine, and my baby was measuring smaller than normal. I remember the morning that I knew I needed to deliver. They rounded on me and the doctor said, we're gonna try to wait until you're 34 weeks. And I was thinking, no, that can't happen. So we had that discussion and they came back later that morning and I said, you know, I am really not trying to be a jerk, but I'm concerned about my baby's growth falling off of the curve. And I didn't want to have an emergent delivery. I didn't want it abrupt. I didn't want to have to run when we know what's going to happen. And I remember she looked at me and she's like, you're scared, aren't you? And I was, but I felt like the way that I was communicating to her was just facts. I asked her if she would call the maternal fetal medicine specialist, and that's who had done my ultrasounds earlier. When I got to labor and delivery, my blood pressures were 200s over 110s, and my baby's heart tone started going down. So the physician that I talked to earlier came in and she looked at me and she said, it was a good call, you needed to deliver. Really, when I noticed that things, or I thought that things should have gone differently, was in the postpartum period. After I delivered, my blood pressures were still extremely high. And the thing that was odd to me is that sometimes I would tell the nurse, hey, I'm not feeling well, can you check my blood pressure? And it was elevated. And so to me, as a provider, if you have someone who just delivered at 31 weeks with elevated blood pressure, you should come and check and see how they're doing. But no one did. And this went on for many nights. So one day the nurse came in, this is the same routine, blood pressure is elevated, and I asked her, I said, can you call the on-call doctor? Tell the on-call doctor that I need to be treated with hydralazine. And so at that point she called the charge nurse, and the charge nurse came in, and she's looking on the computer and typing, and she says, and I said, at what point are you guys gonna treat me? And she said, oh, everybody doesn't get that medication. We have times when we give it and times when we don't. And I said, I know when the medication should be given because I'm an OB-GYN. And so then she left out, she comes back in, and they give me oral hydralazine, which is not what's indicated. You should give IV. And I remember the nurse pacing around the room, and as they're giving me the medication, and I told her, I said, I don't want to have a stroke. And she didn't even look at me in the face. She walked out of the room, and they never came back. The blood pressure went up again, and I said, call my doctor and tell her I want her to come to my room. And so she came to my room, and I said, I can't have my blood pressure this high. It can't stay this high. And I told her, if you need to call cardiology, call somebody. The blood pressure has to come down. And so at that point, they started another IV. They gave me IV blood pressure medication, and I went to the ICU. But this should have happened postpartum day 1. I was so scared. And you, as a physician, you're not used to being on that side. And I called one of my close friends, and I told her I was going to leave the hospital against medical advice. And I was going to go to the hospital where I practiced because I know that they were going to treat me. And she told me not to leave. I mean, I was bawling, I was crying, and I was thinking, what if I have a stroke? What if I'm incapacitated? I was 35. This is my first child. I can't have a stroke. I remember understanding that something went wrong. But somehow it kind of felt like my fault. Maybe I should have, how could this have happened? How could it go so many days? And I just kind of tucked it in. I was it's over, I'm healthy now. And I really did not think about this again until I started working on the work groups for maternal mortality. Until I started hearing the other stories, I was oh my God, this really happens, and people are telling the truth, and people, sometimes they aren't listening, and it's dangerous. The major point that I would like to express to the lawmakers is that it is really important to understand that prenatal care doesn't stop at the time of delivery. It is really important for women to have care beyond that point. When we look at maternal mortality, we know that cardiovascular disease is one of the leading causes of death. What would be amazing is if Medicaid lasted 12 months postpartum. Women need to be able to follow up for a full 12 months in order to make sure they have healed, they have received the appropriate treatment before they enter into another pregnancy. So that would be my major message to lawmakers.
So Erica had her baby in 2016. So this is recent. She has a healthy baby now. He's 6 years old. He is thriving, but he spent about 2 months in the NICU. Erica spent he spent about 2 months in the neonatal intensive care unit. Spent about a week in the ICU herself after receiving that medication. And so, this is just but one of the stories that we have heard, and I'm sure that y'all have heard similar stories as well. And so Dr. Nicole Redman, she is the medical director at the National Heart, Lung, and Blood Institute at the National Institutes of Health, and she has said, "We tend to conflate race and class and assume all problems are due to poor women of color lacking access to care, but Black women at all income and educational levels experience bad maternal outcomes." So you saw this with Dr. Giwa. Other stories that I'm sure you've heard in the news, Serena Williams, she's the GOAT for women's tennis. But her birth story, she was experiencing pain after delivery, and she was ignored essentially by the hospital staff. And eventually she got the care she needed, but she had blood clots in her lungs, and then she had a C-section, and she was hemorrhaging at her C-section. But it's only because she eventually was able to get someone's attention that she got the care that she needed when she should have gotten it at the very first point in time when she herself noticed something. We also saw a similar story with Shalon Irving. She was an epidemiologist at the Centers for Disease Control and Prevention. She was a lieutenant commander in the U.S. Public Health Service Commission Corps. She dedicated her life to understanding how structural racism, intersectionality, trauma, and violence influence health disparities over a lifetime. She had a baby. About 3 weeks postpartum, she didn't feel well. She noticed that. She told her doctor, but they were like, "You're fine." She experienced a cardiac arrest, and she passed away. And so these Black women, normally we think of race and class, social, economic stability, education. Those are all protective factors, we think, normally. But that was not true in this case. That SES and that education, that higher education, did not protect any of these individual women. There's a study that recently came out. It looked at over 2,500 women across the United States, pregnant individuals, and they revealed through their study that 1 in 6 pregnant women are mistreated during pregnancy. And that could be loss of autonomy for them allowing to have control over themselves and their bodies, for being shouted at, scolded, or threatened when they were asking for something, for being ignored, refused, or receiving no response to their request for help. And regardless of the mistreatment that was occurring, women of color were consistently higher. And then regardless of the individual, the mother's race, having a partner who was Black, it increased that reported mistreatment. And so disparities are multifactorial. You've heard that today. But the research has determined that the one contributing factor that does exist to those disparities is implicit bias. And so this is a very large topic, various forms of racism. I'm not going to spend a whole lot of time because I don't have a whole lot of time, but wanted to walk you through these 3 levels that you may or may not heard of. Every form of racism that exists can be viewed as a framework, and it represents different ways to understand our contemporary forms of what's going on in that production of racial inequities. And each has a different effect, and it points to different strategic responses that could be done. Individual racism is at the top, and this is not what we're talking about in implicit bias. But individual racism, that includes that face-to-face and the overt actions towards someone, expressing prejudice, hate, or bias. The next kind of level that you see there is that institutional racism, referring to policies and practices that are within and that are across institutions that intentionally or not, they are producing outcomes that chronically favor a racial group over another, and therefore puts disadvantages at other racial groups. And then structural racism, this is a system in which public policies, institutional practices, cultural representations, and other norms perpetuate that racial inequity that we see. We have history, we have culture here, and it's not something that just a few people or institutions choose to participate. It is something that is within our system, and as we work to how do we really dismantle what our system has produced. This is a different way of understanding our inequitable conditions and the policies and the practices that are out there that are creating those racialized outcomes that we see, those disparate outcomes that we see in our maternal and infant health. So what are we doing here in Houston? We are very proud to be part of the work that Harris County Public Health is doing, and at March of Dimes, we are working collaboratively because we know there's not one organization out there that's going to solve our maternal and infant health outcomes. Our mission is to improve maternal and infant health outcomes using an equity and a social driver's lens. We are using data in order to inform the work we're doing moving forward, just as Harris County Public Health has. And we are looking at results, and we are focused on mobilizing communities. Our vision is that we imagine a world in that every mom, every birthing person, every baby, I'm sorry, y'all, before, during, and after pregnancy, regardless of where you live, regardless of your socioeconomic status, regardless of your race, everyone has that opportunity to have a healthy birth. And so through collective impact, here in Greater Houston, we have a shared vision for all women being able to attain optimal health in all phases of life, including healthy birth outcomes. And we're working in 3 different strategies in which we can do that. Using collective impact, there are 5 essential conditions that have to be met under the, let's say, Collective Impact 101 frame. But what we are doing here in Houston is we are saying we are centering equity in all of the work that we are doing. The authors of Collective Impact have 5 conditions on how do you center equity within the work that you are doing, and what does that mean to your organization. And so I don't have I don't have time to talk through every single one of these conditions today, but the one that I want to tell you, and hopefully you've heard, is that we are working with, we are acting with, we are listening to our community, because it is their voice, it's your voice, each of you and your perspective that you bring to our work. That is going to be what is going to allow us to move forward to change the trajectory in the outcomes that we have. And so this is just but a few of the organizations who are a part of the collective impact work. As you can see, it is multi-sectoral because it's not just healthcare that needs to change. It's our social service organizations. It is government. It is foundations that are contributing dollars to funding the work. And it is because each and every one of these, as well as others who aren't listed, that we're able to move forward and to do the work together. So with that, I think we have some time for a couple questions potentially. Okay. This is also my contact info. If anyone needs to find me, I'll also be here for a little bit.
Excuse me, I have a statement more than a question. Well, some of the things that I would like to share that I experienced when I was pregnant in my 40s. For one, I did not want to have an amniocentesis, and I was talked to in a very disrespectful way as a result of that, despite the fact that it didn't matter what was going to be the outcome. Why did I need to do that? We already know that there are some challenges that comes with doing that test that causes problems. Yet it was very disrespectful the way I was handled. The other situation was that I wanted to have a home birth, and my midwife worked for an OBGYN. As I shared with some of the doctors earlier, she informed me that I couldn't tell my OBGYN. I could not share with my OBGYN that I wanted to have a midwife, because I was told, even though she worked for her, that she wouldn't have given me prenatal care if she would have known that I really want to have a midwife. So I had to go all those months in deception because I couldn't tell her because of fear that she would not provide my prenatal care. My water broke, and for 2 days my child didn't come out. And so then my midwife was concerned about her license. She's like, okay, you're gonna have to go in. We waited 2 whole days, and then when I went in, the level of disconnect in that hospital, they were so cold. They barely gave me any eye contact. They're so busy on the computer, treating me like they're robots, and I'm a robot too. And the difference with my midwife was that it was care and love and touch, and it was a totally different
interaction. They gave me way too much Pitocin to the point that I was having convulsions. I couldn't even talk because of how much Pitocin that they had given me. And it took someone running out of another room who was monitoring to come in and tell them, lower her dosages, low. I couldn't even say, I was trying to say to my husband, I was trying to say his name. I couldn't even get his name out because of how much Pitocin they had given me. I wanted to have my birth, I wanted to squat my baby out. I did not want to have my legs up in the air. I wanted to go the way, the ancient ways of birthing. And so I had to fight and advocate for that. And so it's just a lot of challenges that goes on in Western hospitals, and the fact that so much emphasis is placed on money and capitalism that has to do with the challenges that we're facing, that most countries that don't even have the level of resources that this country has, yet the number of deaths and the challenges that we're facing in this country are not being faced. So we really need more support for midwives and for doulas. And when she was in the hospital, they talked to her so nasty when she provided me support. They were telling her, you know, you have no jurisdiction here. You have this, and we just had to ignore them and focus on ourselves.
Yeah, thank you so much for sharing your story. And you know, we absolutely believe there's a role for midwives and for doulas as part of the medical team for a midwife and as part of the birthing team and the child care team for the doula. So thank you.
Yeah, I wanted to make a comment. My name is Tanya Brooks. I'm a midwife. I've been a midwife almost 50 years, so I'm actually a little old lady. I also have a master's in physiology, and I'm a research scientist with an expertise in brain injury. So I devoted my whole career to preventing brain injury, so I know quite a lot about tough labors, hairy pregnancies, scary pregnancies, and all of that. First of all, I want to say that we absolutely have to focus on the quality of care that women get, because the March of Dimes is absolutely right. Mortality occurs at all levels of finances. And I'm not saying that money doesn't make a difference, or education doesn't make a difference, because both clearly do. But the thing that we must absolutely focus on, and I have reviewed about 25 years worth of maternal deaths data for the state of California, and particularly the county of Los Angeles, and now I'm in Houston. But every single one of those deaths, I'm telling you right now, was because of technical errors. And the technical errors occurred because either the provider did not listen, or there was a disconnect with the nurses, or they were super busy. So we have to have integrated health care where midwives, who are the first line of defense and out in the community, can be brought in. And I have to say that I do not think, after looking at statistics for many, many years, that doulas they're certainly wonderful for moms, but doulas are not medically trained. And if they're sitting out at a home with a mother who has complications, and then they're bringing her in late, the hospital may have no recourse except to section that mother, because they've got to rescue a baby that, if she had been in the hospital earlier, or a midwife had been there evaluating how that mother and baby were responding to the contractions, they would have had a better outcome. So these are things that do not require having to dismantle anything, where we can actually put that in place right now. We have the resources, we have the tools, and every single time that somebody nearly dies, it's because there's ignorance somewhere. We absolutely have to have comprehensive, in-depth childbirth classes, which include how to access your community resources, and those have to be in every community. They have to be available to every pregnant woman at every level. And then those community classes have to include information on the neonate, on newborn babies, and what doctors and midwives are looking for after birth, so that mothers know when to ask for help. So if we do those things right now, we can significantly lower the death rates.
Thank you for sharing. Okay, I'm getting the wrap-up signal. So thank y'all so much for your time today, and I'll turn it back over to Michelle.
Thank you so much, Alicia. Our next topic of discussion will be the state of Black maternal health and healthcare systems. I would like to welcome to the stage Jolandria Porter.
Grant. My name is Patty Gully, and I'm a midwife here in Houston. I own Cypher Birth Center. I've had it for about 10 years. I have served around 500 birthing families over those years. Midwives in general are pretty low volume, so that's number's not super impressive to an OB, but I feel good about it. I don't really know what else to say other than I'm a licensed midwife here in the state of Texas serving birthing families. Thank you.
Hello everybody, can you hear me? Awesome. My name is Kara Alexander. I am a client of a midwife. My late great midwife, Buffalo Hassan, who serviced in the 3rd Ward area right here off of Barbie Street in Houston. And I remember Miss Patty always being at her house, so I have a relationship with her as a friend of my midwife. And I'm just excited to be here and talk to you guys about my experience and what led me here.
Hello everyone, I am Brianna Gant. I am a certified doula here in the Houston community. I am also a registered nurse. I've been a registered nurse for about 4 years now. I've worked outside of Houston along the border of Mexico, and I've also worked for Harris Health System as a labor and delivery nurse. So I've had a lot of different experiences here in Houston with the Black birth community, and that's how I'm kind of working as a doula now to bring that access to, Houston, because it is definitely needed. So that's a little bit about me.
So we had just a slight slip up. We're going to reintroduce the panel because it's called Alternative Birthing. And so I think you all again just want to reintroduce the title again, okay? I'm so sorry. Forgive us. So we're going to get straight into the questions if you don't mind. How would you describe your scope of practice? Want me to go first? Yes, ma'am. So I actually made notes, but I'm going to depart from all of those after these discussions today. So I'm going to talk a little bit about what midwives are, because the biggest problem that we face in the medical community is them not knowing who we are, what we do, and why we do it. So I'm going to talk about the 2 kinds of midwives that exist in Texas. Well, there's probably 3, but I'm going to talk about the 2 specifically that I have the most information with. One is a certified nurse midwife. They have a degree in nursing, a bachelor's degree in nursing, and then they will have a master's degree in midwifery studies, and they can practice inside and outside of the hospital. They, just like licensed midwives, which is what I am, they follow the course of a normal, healthy, low-risk pregnancy with women, with birthing people. And we transfer out of care when complications arise into the medical system. I'm a licensed midwife, which means that I also have a degree in midwifery, but it's not with nursing first. I did follow the apprenticeship model, which I did for several years in Texas and other places. So it's a little bit more grassroots, perhaps, but we specialize in normal, healthy, low-risk pregnant people. We do not do complications. How we define low risk is sometimes a little bit different than the medical industry, but that's neither here nor there. It's important to know that both of those practitioners are licensed by their licensing boards, their separate licensing boards, but we are licensed by the state of Texas on one level or another, and we are independent practitioners for healthy moms and babies, meaning we do not have to be overseen by the medical community. We do not have a doctor that makes sure we're doing our job correctly, because we are experts at what we do. And so we don't need that. That's the question I get most often from doctors is, oh, who's your overseeing doctor? Nobody. Nobody. Okay? We know what we're doing. At the end of the day,
you know, we are good at what we do, and we work within the expectation that we will get support and help when we need it from the people that are also good at what they do, and that's OBs and MFMs and neonatologists and perinatologists and different people like that. Basically, that's my scope. I followed the course of a normal pregnancy, as I always say.
Okay, so is that working? Can y'all hear me? Yeah. Okay. So as a doula, the primary role that we provide is support. Okay, and support throughout the entire life cycle of the female, whether it's at conception or sex or fertility or pregnancy, postpartum, birth. Those are the different realms in which doulas can help and support people in these very intimate and transformative periods in their life. And in addition to support, you know, education is one of the very, very strong roles and factors of the doula, you know, to educate not only just the birthing person, but the family as a whole. And in my role as a doula and as a registered nurse, I found that, you know, education is one of the biggest things that, you know, can make or break an outcome. Because a lot of times people just walk into spaces and walk into birth not knowing, you know, their experience comes from others and people in their family, and that's all they have to go off of. And if all you have to go off of is somebody in your family who had a cesarean because they got induced, and all they had to tell you was, girl, those contractions suck, not knowing that those contractions were induced by Pitocin, an intervention provided by the medical system, that is what, you know, can make the difference between this person choosing a better option for themselves. And so that's another thing in the education umbrella we do, is inform people of their options, because most people don't even know what a midwife is or what a doula is, or even that they can birth outside of the hospital. And so that's really one thing that I drill to my clients, is that you have options and that you should exercise every single last one of them, because as a patient or as a person and a human being in America, you have right to do so.
Thank you. That actually leads into our next question. What is the difference between a midwife and a doula?
I guess I'll go ahead and continue. So, the difference between Patty and I, the biggest difference, and I was just talking with somebody about that earlier, is the medical component. We provide that support and that education, and we work very well with midwives because we all kind of practice from this physiological birth. You know, we have this respect for it. When it comes to the medical side of things, that's where the midwife comes in. I cannot legally catch a baby. I cannot legally diagnose you with anything, but I can know that information and share that with you and be like, you maybe should go and talk to your medical professional about that. And that's one thing that people have to understand, is that the midwife is just as trained as your OBGYN to manage scenarios and situations. And the doula, we stay in our role of just supporting everybody through that entire experience.
Would you like to add? Okay.
I guess I should clarify that we do actually monitor mom and baby's health, urine analysis and all that good stuff. We do all that. Just thought I'd tell you.
Thank you so much. Miss Alexander, can you please tell us about your experience and decision of choosing an unmedicated home birth?
So I made this decision a very long time ago. I actually made this decision from another documentary called The Business of Being Born, narrated by Ricky Lake. I don't know if you guys ever seen it, early 2000s. I even had a husband, before I had a spouse. I was like, I'm gonna do this, and I hope the person that is with me is along. And that documentary hit me how to accept it and roll with it. So that was what led me there.
Okay. Do you mind sharing with us some of your pros and cons of birthing center versus hospital settings?
So I don't have that much experience with hospital birthing versus home birthing. A lot of my friends do come with complaints saying they weren't allowed to birth or they had to wear masks. A lot of my friends did get pregnant during COVID and they had to wear masks during their birth, whereas I was walking around the house doing my thing in labor with my mom, my husband, and my midwife. There were not people in and out of the room, people I didn't know. So I say in the hospital sense, there's not so many rules within a home birth. It's kind of your space. It's your time. You're the star of the show. There's not a doctor that comes in. He's like, all right, let's get it started. Like, you set the tone for everybody else in the room. It's your space and not a hospital space.
Thank you. What are the overall benefits of using a community-based care option? And this is for everyone on the panelists to answer.
Community for me is I am a Houstonian and I went to Texas Southern, so having my midwife right there in their ward was just perfect for me. I knew where I was going. I wasn't rushing. I didn't have to do a dry run. So having her right there in the community, she was also able to introduce me to her other clients. So I had a circle of moms that I wouldn't have never met without my midwife. So it was great to have a community outside of my immediate family.
All right, so there are benefits to the birthing families. There are also benefits to the medical community for utilization of community-based midwifery. For the medical community, to be honest, we're like a pressure valve. We take off the burden of normal births so that they can focus on what their training is. I mean, they're trained to take care of slightly more complicated pregnancies and to do surgeries. And they're very, very good at it. I mean, they're excellent at it. And when they can focus on that, you get better outcomes. You just do. So we help improve outcomes by taking things out of their realm that they don't need to be messing with. We also are great for birthing families because we're able to become part of the family. I have clients that I've delivered 4 or 5 babies for. They still come visit me. They bring their kids. I get pictures. Their kids are 10 years old. You know, we are part of their family. It's important when you go into labor as a birthing person to not feel like there's strangers in your space. It's like animals when they birth, they always look for that dark space and they don't want anybody around them that doesn't make them feel safe. People birth best in that environment. And that's what midwives do. That's what doulas do. We go into the space with the energy that we're matching for the family, and we allow nature to take its course in the safest way possible. Meaning, of course, we monitor. And we want to make sure that if there's anything that looks like a complication that puts mommy and baby at risk, we're going to talk about changing the plan. We're going to talk about changing the plan if it's necessary to something different at home or the birth center, because they're kind of the same, really. There's no big difference. Or going to the hospital. The problem is, occasionally we end up hesitating going to the hospital because of the reception that we receive, that birthing families receive, the way that they're treated once they get there. Like pariahs, like people that are irresponsible who don't know about themselves and what decisions they're making. And that hesitation is a disservice and should never exist. And that speaks to what one of the ladies was speaking to about how she was treated when she transferred, how her midwife was treated. We've all experienced it. So we benefit the medical community, we benefit the community at large. Midwives have always been part of the community. When you come to someone who lives in your neighborhood or lives within a radius, they know if you live in a food desert. They know if you are, if you go to this church or that church, they know who you're surrounded by. They understand the stresses that you deal with on a daily basis and an hourly basis sometimes. They know if you have transportation or if you don't. They know that if you have access to the kind of foods that they're recommending that will help you, they know if you can get the supplements that you need to have a healthy pregnancy. And they will find ways to help you get those things if you don't. And it doesn't have to be a big shaming discussion about why you just aren't as good as the next person because you don't have those resources. It's just providing what you need.
So as far as doulas and their huge, role in the community and what they provide is, I feel like it's resources, because I always like to look at myself as like a resource hub for a lot of different things. One big, huge thing, of course, is just finding a midwife in itself. Most people don't know that there are birth centers, and there are quite a few midwives that practice here in the Houston community. So quite often when I have consultations with clients, I'm sending out, this very long resource list of like, okay, these are the midwives on this side of town, and these are the people offering home birth options versus birth center options. And, just making people aware, again, going back to the option side of things, of you have options in your entire pregnancy in terms of the type of care you receive. Like, you don't have to just, go see an OBGYN and that's it. You can go see a midwife and an OBGYN, or you can just see the midwife, or you can go see pelvic floor therapist, or you can get your lactation consultant in pregnancy and establish that. That's the whole thing about education, and what, our main thing as doulas we do is just making sure people know that this is a type of support and care that is going to influence and better your outcome, because it's not always just about preparation for pregnancy, it's also postpartum. And that's when your doulas really get to come in and shine, because anybody who's had a baby before knows having that extra set of hands is amazing in everything, and it can really make or break the difference in postpartum outcomes, because postpartum depression is very real, and one of the huge components of that is lack of support. And a lot of times, especially in the Black community, support is just not something that we have, and related to breastfeeding, because just like she said, sometimes you're the only family member that has breastfed in the entire family, so then now you're sitting there like, what do I do? And then that's when the doula can come in, provide resources or just general education on how to do these things and make that transition into motherhood for that mother, for that family, 1,000 times better. So yeah, that's usually the role of the doula.
Thank you. What does an individualized care plan and birthing team consist of? Do you mind giving examples?
Well, okay. It's hard because it's literally individualized. Like, it looks different for every family. I guess some examples would be, families where one of the things is, my favorite thing is to have a partner or a family member who is really important to the birthing person catch the baby if that's what they want to do. Catching the baby is about 1% of what I do. Most of what I do is emotional. I mean, of course there's the medical side of it, like I said, but it's emotional. And so we individualize based on what's happening with the family. For instance, I have one family that they started out very young, at 16, and they've had 3 children, and they're fantastic parents. They never came in feeling like I thought they were less than because they were young and because they weren't married. And the things that they immediately are going to be set aside for in a different environment. These kids are raised in a very loving environment, they're fully supported, and I don't know that they would have had that same transition into parenthood if we weren't able to see them and believe them and support them in the way that they needed as a young couple. We try to get resources. For instance, I have one client that doesn't have access to her birth certificate because of a family issue. So she didn't have any way for us to be able to put the father on the birth certificate because she doesn't have ID. I called the state and did everything I could to work that out, and we found a solution and got her what she needed. I'm not sure, how much more individualized we can get, honestly. I've been texting with clients all day while I'm here, telling people do this and do that because that's what they need. They can text me anytime, day or night. They can call. I prefer they don't call me at 3 in the morning to ask me a question that's not birth related. But they can though. Like if there's something going on that they're scared about or they're worried about, they can contact me 24/7. They don't have to worry about going through a call service. They don't have to worry about going to the emergency room to get, unless there's emergency, then obviously we're going to do that. But I'm saying they don't see me as just a provider. They see me as part of their world. And that is how we individualize. We provide diets for people that need a certain type of food because of gestational diabetes or hypertension, but it's culturally competent. I know what I can give to one particular family versus another. If they're vegan, I'm not going to go tell them to go eat meat if they're low on iron. That's just not going to work. They're not going to do it. That's the whole point. It may be a valid suggestion, but they're not going to do it, and they shouldn't because it's not part of who they are. So, I don't know. It's a hard one for me to answer, obviously.
For me, it's a lot easier to put in perspective because as a registered nurse, like being in nursing school, that's all we did was care plans. Okay, so individualizing the care of your patient is a priority because everybody's an individual. You know, nobody's gonna birth the same, nobody's gonna breastfeed the same. Nothing's gonna be the same. So when I speak to my clients and I empower them about their options, one thing I always ask them is, what are your birth preferences? What do you prefer for this experience? So that way you, your family as a whole are satisfied and fulfilled from that. And that's something that, you know, goes back into options and really just kind of running through like, okay, if you're birthing in a hospital space, this is the typical flow of things. So what within that do you not want, you know, a part of your experience? Birthing center or home is a lot more flexible because you spend majority of your time at the home for the birthing center, and then of course when you're at your house, you're at your house. And it's just kind of figuring out in that setting, what do you want in terms of you? Do you want aromatherapy? Do you want dim lighting? Or do you want us to have, you know, trap music on while you're laboring? It's your preference. It's whatever is going to resonate with yourself. You know, I've seen it all. You know, supporting people in births, I have seen it all. But each one of those birth experiences were 1,050% different because they were empowered to realize that they could do that and be an individual. And that's something I find as a registered nurse working in the hospital and working in the medical model of care is that things aren't individualized. Things are definitely more textbook and black and white. And when you don't fit that criteria, you're thrown over here and treated a certain way as a result. And that's just not fair.
Thank you. We're gonna pass this mic because they're saying they cannot hear you all when they're talking, so I'm gonna just speak and then pass it. So what are some of the barriers you foresee as an issue of accessing midwifery and doula care?
I think the only issue I ever had was being able to bill it on my insurance. Insurance is like, we don't cover home birth. So I did pay out of pocket for my midwife cash. And I did register at a hospital just as a plan B, and they ran my insurance, and it was the same exact price with insurance and a midwife. So I think Texas should probably implement laws about adding midwifery and doula care through your insurance, because a lot of people don't have access just because of financial reasons. And it blocks a lot of people that are interested or would love to do it but cannot simply afford it. And it's not a luxury because you're still giving birth, but it is something that everybody deserves to have access to and have that option to.
So lack of education about really what midwifery is and doula care is and how it impacts their experience, not just for their birth, but for their postpartum period and really for parenting, is probably a big one. Finances obviously is a struggle for so many. I get at least 4 or 5 calls a day asking if we take Medicaid, and unfortunately, Texas makes it extremely difficult to get approved for Medicaid as a birth center, and they don't cover home birth at all. So people who are on Medicaid don't have access at all to those types of things as a general rule. The biases in the medical community against out of hospital care, they're very fear-mongering, and they're very, very aggressive. And so that really pushes people to an understanding that isn't realistic. So that's a definite barrier. And just a lack of confidence in birthing people anymore, being told how they just can't do anything for themselves and they have to be taken care of by a specialist.
Yeah, just to piggyback on everyone else, like finances for sure. That's a huge, huge one I see on a regular basis. Excuse me. Because people just, you know, we live in capitalistic America. You know, you have other things to consider, and sometimes people can look at, you know, doula services or even midwifery care as, like you said, a luxury, when reality, like, this is your life. This is something you should be investing in. So that's why, you know, offering payment plans and things like that are something that a lot of, like, midwives and doulas do in an effort to try to provide the community with these options, you know, despite the fact that insurance companies are just not covering these things. And, you know, the insurance company itself is a part of the broken structure, and that itself needs to be fixed as well. And as far as outside of financial barriers, people just don't know what doulas are. You know, going around actually understanding the difference between what a midwife and a doula is, making sure the community is aware that, you know, there's different types of doulas. You have options to have that labor support. And also, people just don't think that it's sometimes necessary. And I always tell people that most of the time you don't realize it's necessary until you're in the thick of it. When you're in labor and your partner on the couch sleep, and your nurse of 30 years that really just wants you to get the epidural so she can go sit on her phone and chart or do whatever. And who's with you? Who's on your side? The hospital has the nurse and the doctor on their side. You got your partner who's on the couch sleep, and then what about you? That's where the doula rolls in. And I really feel like every single birthing person, I don't care if you first baby, eighth baby, you need a doula.
Thank you so much. As we are wrapping up, I just want to thank everyone on the panelists today just for your experience, your knowledge, and basically, I'm not going to lie, you educated me a lot. I wish I had a doula during my pregnancy, I promise you. And I am going to thank you again. I'm going to turn it over to Michelle. Thank you.
Thank you for moderating, Durandria. Okay, so for our next session, it will be over the state of maternal mental health, which is very, very important. I would like to welcome Michelle Parker-Shaw.
Okay, afternoon, everyone. I am of Trinidadian descent, therefore I talk with my hands. Thank you, Ms. Harrell, for your introduction. And I want to especially thank Mr. Adrian Turner, wherever he may be running around, for inviting me to exchange my participant registration for my speaker registration today at this summit. I'm truly humbled to be able to share this overview of maternal mental health as experienced by the Black birthing community. By the end of this conversation, I hope that we'll understand the description of perinatal mood and anxiety disorders. I will be referring that to as PMAD, because four letters is better than 4 words for me right now, highlighting inequities that exist for pregnant and parenting women of color. My hope also is that you will clearly see the barriers to accessing screening and treatment of these disorders for those suffering with symptoms, as well as the hurdles created by social and community norms. I would like to also get us together to envision how increasing maternal mental health literacy, which is something we've all been discussing today, and reducing roadblocks to screening and treatment for PMADs, and how they can improve outcomes for maternal and infant mental health outcomes, creating healthier Black communities writ large. The contents of my presentation don't necessarily directly align with my affiliation with Baylor College of Medicine, so we're just going to leave that statement there. Up to 2 weeks after giving birth, many women, approximately 80%, experience sadness and or mood swings. This common experience, irrespective of demographics, can usually resolve organically without additional treatment. If some symptoms worsen or don't resolve over time, then screening and intervention for PMADs should be the next step with your healthcare provider. Mental health conditions under this umbrella include depressive disorders, anxiety, panic disorders, obsessive compulsive disorders, post-traumatic stress disorders, bipolar disorders, and psychosis. The onset of these illnesses can begin prior to pregnancy and extend all the way up to 1 year post-birth, postpartum, which defines the perinatal period. The onset of any of these disorders, of course, can occur outside the perinatal period, which increases the risk of reoccurrence for a perinatal person. PMADs affect 1/5 of pregnant and postpartum women in the United States, and despite clear and established symptoms and treatment courses, nearly half of all perinatal women go without care or treatment for their diagnoses. Untreated PMADs interrupt a mother's ability to physically function through daily tasks, effectively bond with their baby, and significantly strain interpersonal relationships with their partner or other close members of their support network. Communities of color are disproportionately represented within the group affected by PMADs. Black women in the U.S. experience PMADs twice the incidence rate of white women and are half as likely to be treated. Close to 40% of Black mothers will suffer from postpartum depression alone. That's more than twice as much the rate of the general population. In 2019, there's an article from the Journal of American Academy of Pediatrics that revealed that more than 400,000 infants are born to mothers who are depressed annually, which makes perinatal depression the most underdiagnosed obstetric complication in the U.S. Mothers with untreated PMADs are at higher risk for cesarean deliveries, death by suicide, and challenges with absenteeism or presenteeism. So you're in the building, but not really there, at work. Similarly, children born to mothers with untreated PMADs are also at risk for developmental and behavioral disorders, such as ADHD, depression, and anxiety. Mathematica, a policy research institute, estimates that the total societal cost of untreated PMADs in the United States is $14.2 billion of all births in 2017. When following the mother-child pair from pregnancy through 5 years postpartum. We could discuss, argue about the importance of infant and maternal bonding, whether it's the first year, the first 3 years, the first 5 years, but at the end of the day, at postpartum onward, it's important. There is no monetary equivalent for a beloved mama, daughter, son, aunt, friend. Numerous research annals indicate that professional help-seeking behavior among Black and African Americans routinely reveal general aversions to psychotherapy interventions and or medication treatment for the alleviation of serious personal distress or behavioral health disorders. So in lieu of traditional therapy, many Black and African Americans typically rely on their intrinsic and informal circles of care and support through family, friends, and their faith communities. The healthy distrust in the healthcare system has moved birthing people to return to traditional community practitioners such as midwives, doulas, and their mothering circles for support throughout their perinatal journeys. In order to improve these maternal mental health outcomes, and by extension, infant mental health and development, an effective implementation of multiple coordinated pathways, and we've heard this already today, of client-centered care steps that must be created to encourage and sustain community-based care. For example, in-home education and intervention are employed by home visiting programs, such as Nurse Family Partnership or the UH Healthy Start. These entities intentionally collaborate with pregnant clients, educating them in typical and non-typical perinatal experiences and symptoms, screening them for common perinatal concerns, and challenging and supporting their active engagement with their perinatal medical care. And the earlier you start, the better the outcome. In-home or community-based programs also emphasize the importance of partner participation, directly involving supportive family members, and knowing that they all too well will be directly affected by the mother's overall mental health and well-being. Both of these programs are designed to provide education, support, and care throughout the entire perinatal period, up to 30 months in the case of nurse-family partnership. This fosters that kind of construction of secure and trusting relationship between the mom and her community care providers. Open and honest care relationships, giving mothers and their families evidence-based treatment in a respectful, nurturing manner has been proven to reduce overall stress, increase resilience to physical and behavioral challenges, and promote a healthy birth experience. And promote a healthy experience of a birthing person's sense of well-being, all of which will directly reduce adverse delivery and birth outcomes for mother and baby. Currently, all of these things are devastatingly absent from current medical healthcare systems for our Black birthing community. So, what's the way to progress? Logistics challenges, for one. Lack of reliable transportation and lack of paid time off for work to attend multiple behavioral health and medical appointments can be addressed by at least co-location of mental and medical providers, or at best, by community-based providers who operate as integrated and interdisciplinary practices. For example, I'll do Golden Girls. Imagine, right? Picture it. A birthing center complete with a healthcare team comprised of an OB-GYN, psychiatric physicians, nurse midwives, behavioral health clinicians, doulas, along with coordinated community case management teams. This super team, if you will, could provide that holistic response to pregnant patients during their appointments and at home in their own communities. While this may seem like a fantastical birth equity goal, I assure you it is not. Holistic and accessible care models like the one we are picturing are the reality in pockets around this country. So our real equity goal is to systematically leverage federal, state, and local resources as a community stakeholder community, so we can extend the pocket-based innovative realities of community-based perinatal services to the most in need, the Black birthing people of America. So in this new reality that we find ourselves in the country, and particularly Texas, we all must ardently advocate for Black maternal mental health equity, because as we know, time and again, it's fundamental to the welfare of all future humans, not just a rarefied few. Thank you very much. Do I sit? Okay.
Okay, thank you so much, Michelle. This is a moment for questions, if anyone has any to ask. Nope. Okay. Well, thank you so much. You know what? I think I might have a question. I think I might have one. What current resources are available for mothers who may be dealing with any prior mental health illnesses or even postpartum?
Sure. So we can think about it in several ways, actually. So if an individual has an existing behavioral health diagnosis, it could be in the realm of being treated or untreated. So let's start with treated. So statistics say that if you have a behavioral health diagnosis prior to preconceptually, you are at high risk for developing an intensified experience or diagnosis during pregnancy, similar to gestational diabetes, let's say. And so the moment you find out that you are pregnant and you're in care, that's the first thing that you want to say to your behavioral health provider. It might be that it's psychotherapy alone, it might be medication alone, or the gold standard would be doing those both. And then discussing with both of your care providers, based on the diagnosis, whether a different kind of medication or the choice to go through pregnancy unmedicated but stay in psychotherapy, or any number of combinations. On the flip side, if you're untreated, then unmedically treated either by medication or psychotherapy, then the likelihood may be that you are self-medicating, and those types of behaviors are generally unhealthy choices, and so that may run you into an issue of seeking unevidence-based resources. And so the healthier choices would be to, if you are, if you have limited resources, using one of the community-based agencies, the federally qualified health centers like Legacy or Avenue 360 or the Harris Center. If you have the fortune to have insurance, then you call your insurance provider and see who they cover to address those pre-existing diagnoses. So that, in a nutshell, is where you can find things. Mental Health America of Greater Houston is also a wonderful general resource for many different providers based on what you think you are experiencing or what a loved one may be experiencing, in order to have a one-stop shop and then pick community resources or community practitioners. Answered the question.
Thank you. Thank you so much. Okay, so we are on our last segment, and it is a call to action, Lessons from California, from Director Dana Sherrod.
Thank you. Uh-oh, let me just move it over. Can everyone hear me okay? Yes. All right. It has been a long day, but a wonderful day. And so I really believe that talking about this really heavy issue, especially because I see so many beautiful Black and brown faces in the room, it sits with us. So I'm going to just invite everyone, if you're able, if you're willing, just stand up for just a second. We talk about this, and for so many of us, it's our reality. We live this. And so it's really important for us to just make sure we're taking care of ourselves. So I'm going to just invite you to take a deep breath in and raise your arms above your head. And let it out with a loud sigh. Shake it out. If you can shake it, shake it, shake it. You guys remember the Harlem Shake back in the day? All right, you can go ahead and have a seat. Thank you. All righty. So it is my truly great honor, great privilege to be here this afternoon. I obviously came quite a ways from Los Angeles, California, but I am so grateful to be here this afternoon just to share what we're doing in California, more specifically what we're doing in Los Angeles County. So before I start, I always like to give credit where credit is due and acknowledge the people that make this work possible. So I want to thank just our very generous funders that make this work really happen, our range of partners across Los Angeles County and really across the state of California who are in so much support for this work. And I too talk with my hands and I like to move around. So I'm going to just take the mic out. So today, I really, there's been so much that has been shared and talked about already. And so what I'd like to do, especially on the tail end of the day, is really talk about a call to action. We have heard a lot of the statistics, we've heard the data, which is incredibly impactful and for a lot of us very heartbreaking. So what my goal is to talk a little bit about some of the strategies, very practical, tangible strategies that we can actually start to implement to change the system. We talked a little bit earlier about collective impact strategies, and I want to just go into what we've learned and what we're doing in Los Angeles. So before I start and talk about sort of some of the work, I love this quote by our dearly departed John Lewis, and he talks about what legacy do we want to leave? So he says, every generation leaves behind a legacy. What that legacy will be is determined by the people of that generation. What legacy do you want to leave behind? So I'm going to challenge us, all of us in this room, and I know we've sort of dwindled throughout the day. It's been a long day, but a wonderful day. But I really want to challenge us. What legacy do we want to leave behind? What story do we want to be able to tell? Do we want to say that we met the moment or that we continued the status quo, right? I have 2 little black girls, and for me, one day they may decide to become mothers themselves, and if they so choose to have children, I hope that I've done everything I possibly can, along with my colleagues, to make sure that they are not dealing with the same things we're dealing with, right? So I want us to think about, what legacy do you want to leave behind? So I think what we kind of all garnered from today is that this moment demands that we act with a sense of urgency, right? I don't think any of us in this room feel like we can be complacent, that we can continue to do what we've been doing because it's not working. So we have to act with urgency. Congressmember Lauren Underwood, who was referenced earlier, one of the co-founders of the Black Maternal Health Caucus, she said, the maternal health crisis demands urgent attention and serious action to save lives and advance birth equity across the country. So I don't want to harp too much on the data, because we've heard really incredible data today, data that really paints the picture of what's happening. What I will call out, however, is when we're talking about maternal mortality rates, not only, as we've heard today, not only are rates, horrible and disproportionate for Black women, but what we've seen in the COVID-19 pandemic, during the COVID-19 pandemic, is that maternal deaths are increasing, and most specifically increasing, impacting Black and Latina women. So we had a speaker a little bit earlier from the March of Dimes. She talked a little bit about preterm birth, preterm delivery. Of course, the March of Dimes puts out incredible data through their report card and their peristats. So I just wanted to call out on this slide, not only are Black women and birthing folks being impacted, but our babies are as well. You can see here that in the United States, the preterm birth rate among Black women is 51% higher than that among all other women. So we got a problem. Now, I do want to talk about California for a minute. I love my state, and most importantly, I love Los Angeles. And for those who have been in this maternal child health space, you know that California has a reputation and a distinction in the country for having reduced our maternal mortality rates, for making significant improvements compared to the rest of the country. Now, when I go other places outside of California, I, am often sort of talking about these differences that we're seeing or not seeing. But when we really continue to look at the data disaggregated by race ethnicity, we can see that California still has a massively disproportionate maternal mortality rate compared to other races and ethnicities. We can see that the disparity ratio increased significantly for Black women and birthing people. So again, we talked today about, why. We talked a lot about the root causes, right? What do we know? Is there something that is driving these disproportionate outcomes for Black women and for our babies? And the common response that we hear is that Black women have higher rates of obesity, we have higher rates of hypertension, diabetes, greater social disadvantage, all of which, unfortunately, are true. And they're very important, I would say, for a healthy pregnancy. However, what we know looking at the data and the research is that protective factors such as our education levels, our income levels, our marital status, all of the things that are generally protective factors are not as protective for Black women. In fact, what we see in the research is that when we control, meaning we hold all things equal, when we control for things like education, income, even prenatal care, unfortunately, Black women are still disproportionately impacted. We are still experiencing worse outcomes. So then the question is, well then, if it's not our education, our income levels or status, what is the root cause of this issue? And what we know, based on a lot of emerging and recent research, is that this issue really boils down to racism, not race. And we've heard that a bit today. We heard and we know that it's the overexposure to racism, discrimination across our lives from the time that we are really in utero. We're children, that we are exposed to so many other things, and that impacts our body, right? We have the weathering effect, meaning our bodies are aging faster compared to people and women of other races and ethnicities. So it's not something inherent about being Black that gives you these poor outcomes. It is the fact that we live in a very racialized society. Now, I like to define what I mean when I talk about racism, right? Because most of the time we tend to think about only sort of if somebody was called a racial slur or being followed in a store, which absolutely is a form of racism. But I really like this, I like the definition by Dr. Kamara Jones, who says that racism is a system of power. Now, I'm sure folks here in the Black church, call and response, so somebody say power for me. It's late, it's the end of the day, say power. Yes, it is a system of power that structures opportunity and assigns value based on the interpretation of how one looks, which we call race. And this power, or this system of power, it disadvantages some and it unfairly advantages others. So this is a really amazing conceptual framework by one of my colleagues and now friends, Dr. Brittany Chambers, who is out of the Bay Area, San Francisco, or was in San Francisco, California. And she and her team looked at sort of how are Black women defining how racism shows up, right? So it's very small, it's not super clear on here, but it talks about employment, unequal employment opportunities, medical care, negative societal views, our housing, law enforcement. These are things that we all know to be true, and now we have the research to validate even further what we already know. What we talked a lot about today as well is different experiences in healthcare. We've talked a lot about that today, and rightfully so. It is well documented that Black women have incredibly disproportionate experiences of disrespect, abuse, and discrimination when we interface in the healthcare system. And unfortunately, that really does have an impact. Uh-oh. You all right? All right, gotta make sure everybody's safe. All right, but we know that this contributes to adverse outcomes for both mom and baby. So there was a paper that was published, and I'm just gonna look really close, in the Journal of Maternal Child Health. One of the contributing authors, my good friend Mashriki Kadumu, who used to be with the March of Dimes, Shantae Davies Balch, I believe in calling the names of incredible folks, researchers, Black women who are doing the work into the room, which is why you'll see I say cite Black women, right? Cite Black women researchers. But what it says in the paper is that there's a lack of safety felt by Black women in the healthcare system. Black women's stress is exacerbated by having to navigate a system that is unfamiliar and at times hostile to them. So I want to talk about what we're doing, right? We know these data, we know our own experiences and those of our loved ones. So what is it that we're doing? I want to share a little bit about the work that I have the distinct privilege and honor of leading and championing in Los Angeles County. And it is called Cherished Futures for Black Moms and Babies. But before I tell you about Cherished Futures, I want to tell you very, very quickly about LA County. Has anyone been to LA? Yes, okay. Or from anyone else from LA? Yeah. All right, so for those that are, it sounds like a lot of folks are familiar, but if you've been to Los Angeles County, we have about 10 million people that live in the county of Los Angeles, which is massive. It is actually the most populous county in the United States. And if the county of Los Angeles alone were a state, we would be the 11th largest in the United States. We have about 114,000 births on average each year. And this number, of course, changes, but we have about, give or take, 46 different delivery hospitals. For context, some states have that many delivery hospitals within the entire state, and this is just one county in California. So the work of Cherished Futures, the work that we're doing, it is a multi-sector collaborative initiative. And our goal, of course, is to reduce Black infant and maternal inequities and really improve the patient experience for Black people in Los Angeles. This work, the way that we've structured it, is that it is grounded in data and Black women's experiences, right? So we know, it's not only that it's, some random person out there. For a lot of us in the work, it is us. We are talking about us. So this work, we believe, has to be grounded in both. So what we're doing is we bring together a range of different sort of decision makers and key leaders, key partners. And I'll talk about that in just a second. But really, we look at how we can change the system. I just talked about how what we're seeing in the research is that, when we control for all things, that Black women are still experiencing worse outcomes. So it's not Black women or Black people that need to change. It's the system that needs to change to produce better outcomes. So in this work, we talk about, systems change sort of in 3 levels or 3 ways, which is the clinical level, the institutional level, and at the community level. So this is a little bit about sort of the makeup of the collaborative. I talked about it being multi-sector. So we have our hospital teams and our community advisors, which I'll talk about in a second. We're bringing local public health departments together, our insurance payers, and our Black-led or Black-serving community-based organizations. So I will also just add quickly, I think I talk about it in just a little bit, but what we notice and what we know is that oftentimes the higher up that you get in a healthcare system or institution, generally you're gonna see a lot less Black people. And it was important for me to make sure we had Black women's voices at the decision-making table. So we created what we call our Community Advisors Collective. So these are Black women community leaders, CBO leaders, researchers, some of them are clinicians, but they are based in the communities that we are most interested in. And we actually partner them and place them as members of our hospital teams. And I'll talk a little bit more about that in just one sec. So Cherish Futures, it's a 2-year cohort experience. The first year is really about capacity building. So we have a series of collaborative workshops or convenings, and the focus of that first year is really to build the knowledge, help people sort of understand why these inequities exist, why we're seeing them, understanding sort of the historical impacts, right? We talk about things like redlining, we talk about things like blockbusting, the disproportionate distribution of federal resources such as the GI Bill, and how all of that has impacted the outcomes that we see today, right? We talk about concentrated poverty, why we see concentrated poverty, right? Well, we know that that's not accidental. It was very much a matter of design. So we have to talk about those things and get to the root of the issue before we can actually talk about the solutions. So as part of that first year, there's 2 sort of critical things that happen. We primarily assess the starting point, right? So where are people starting from? And I'll show you sort of the way that we do that in just a second. But the focus of that first capacity building year is that all of our hospital teams in particular develop an implementation plan or an action plan. The second year, which is the implementation year, is really when those plans get put into action. So we are most, I would say our largest sort of driver in this work for producing change is through working with our hospital teams in particular. We know hospitals, of course, are only just sort of one stop in this long journey, that the work has to happen, as we heard earlier, before pregnancy, during pregnancy, and after pregnancy. But year 2 really is the implementation year. And that is where, our teams are actively, implementing the things that they have talked about. So just a sneak peek, since so many folks have been to LA, and I'm happy to hear it. These are some of the hospitals that we are working with. We're currently on our 2nd cohort of hospitals, which you can see on the screen. And what's so fascinating is that the hospitals, technically there's 9 of them. UCLA has 2 delivery sites that are participating. But the hospitals from both of these cohorts deliver about 45% of the Black births in Los Angeles County. So when we think about impact and who's serving Black people and Black families, we are really trying to reach in and grab those that are touching us most directly. So I won't spend too much time on this, but I talked about really wanting to make sure that this work is grounded in Black women's experiences. There's a really incredible resource that was developed by Shante Davies Balch and some of her colleagues around power sharing with Black women, principles of how you engage and how you work with Black women. It is online, it's available, and I encourage folks to check it out. But this is really a grounding sort of way in which we engage all of our partners to work with Black women. So I talked about sort of the importance of us elevating this Black voice, thought leadership, our experiences. I mentioned we do that one way through our community advisors. The second is that we have what we call sort of our Black women listening sister circles, or we host sister circles. So we are in essence inviting Black women into, well, because of COVID, mostly a virtual space. And it is a time for us to hear from sort of the broader collective of voices, right? Because we're not a monolith. We know Black women have very different experiences. And we want to hear, what is it that they would like to see change in the healthcare system? And then we report that back to our hospital teams, and we tell them, this is what we heard from Black women in community. And I will just mention, I didn't want to put a video in because I figured, time might be short, but it is on our website at cherishfutures.org. We have sort of recap videos of sister circles, of Black women sort of sharing their thoughts. And you can see one of the quotes listed here. So something that I just also wanted to quickly call out is that I talked about in our first year, the first year experience in Cherished Futures is really about capacity building. And part of that is we have what we call our organizational birth equity assessment. This is an assessment or a tool that we developed to help each of our hospital teams in particular assess themselves and determine a starting point. So there's a series of sections. Each section you get in essence, like a composite score, you get a score. So if you're just barely starting on working on this, you might have a very low score. In some areas, you may be very advanced and you have a high score. And that then correlates to what we call our menu of interventions. This is a sort of compendium or collection of strategies that are evidence-based and community-informed, because we know there's a lot of barriers around getting research evidence-based is a whole nother argument. But we compile these to look at opportunities to, again, address the system. How do we change the system so that it is performing better to support Black people? So ultimately, our teams will look at this menu of interventions. They take their sort of score where they're starting from, and then they can identify what types of strategies they might want to implement. For reference, because I didn't include it in here, but some of the strategies are things like, are you consistently looking at your data by race, ethnicity, discussing it in, existing OB committee meetings, or, wherever folks are naturally already sort of coming together. It talks about hiring practices, looking at how folks are investing in communities. Are your investments and your investment strategy in alignment with public health and others? There's a whole range of strategies depending on where folks are starting from. So very quickly, I want to just kind of talk about a couple key lessons and things that we have learned since implementing this work starting in 2019. So there was an article in the New England Journal of Medicine by Amy Reed and other colleagues that talked about how institutions or organizations can advance sort of equity work. And one of the frameworks they introduced was called the Getting Grounded phase, which I really, really like. And there was sort of 3 steps to getting grounded. The first was to build the container. And so that is basically creating the space where folks, just like we're doing today, can come in, talk about the issue, explore strategies or solutions. So a couple things that I took applying sort of this framework is that we have to identify a backbone team or convener, right? So Harris County Public Health has done an amazing job bringing folks together today, serving as a backbone supporting organization. So, the second would be network mapping. Who should be at the table, right? Sometimes, especially in LA, it's huge, but it's also very small. So we tend to call on the same people over and over and over. So we have to think about who's not at the table, who's missing, who should be here. So build the container. The second, which I talked a little bit about, is to understand the historical context. One of the things that one of our physician partners talks about is how does racism show up here specifically? How does it show up in your institution? How does it show up in your community? Be specific and concrete. And we encourage folks to learn the history, right? So there's the history at the national level of what has happened, how we got here, but there's also your very local history. What's the history here in Houston and in Harris County? How does that show up? In Los Angeles, it's very different. We had, the Highway Act that came in and ultimately built a series of freeways and displaced a lot of Black families, moved them out of their communities by eminent domain. So what's the story? What's your history? Of course, spending time in community and acknowledging that patients have various experiences. The last is to assess the data and the state of equity. So we always talk about disaggregating data by race and ethnicity, which today we heard and has been incredible. That's such a huge step and a huge starting point. How else can we look at the data? Can we look at it by geography, such as zip code? I think here y'all have wards. We have in Los Angeles, we have service planning areas or spas, which are massive, but we can look at it in a couple different ways. And then identify a baseline of existing efforts and readiness, because we can talk about this work all day long, and if folks just do not want to do the work, we're going to see maybe very incremental changes. We have to get ready, because remember, the situation is urgent. Couple other really quick key lessons is that leadership, especially when we're talking about working with our hospitals in particular, they have to be engaged and in support, or we're going to have pretty nominal movement. The second is to include Black staff and to recognize their experiences. Because again, it's not just those people out there. Many times it's us, it's our sisters, it's our aunties, it's our friends. So they have experiences, especially within the hospital systems as well. One shared value that we have in Los Angeles County, across Los Angeles County, is that Black women and people should be upfront and leading. We didn't cause this issue. It's not up to us to solely fix this issue, but at the same time, we have the expertise because we bring in both our lived experiences and our professional experiences. So Black women should be upfront and leading. And then the last is just about a variety of partners, which we heard about earlier. And I want to show you very quickly what it looks like in LA, what we're doing specifically. This is incredibly small, so I don't expect you to read this. But the Los Angeles County Public Health Department really has adopted this issue as a very key area of concern. So slowly we have built infrastructure since 2018 to do this work collectively. The initiative is called the Los Angeles County African American Infant and Maternal Mortality Prevention Initiative. Say that fast 5 times. AIM is the acronym, and we like to call it a collaborative of collaboratives. And so in the center, you can see we have a steering committee which I am happily a member of. And these little dots around the middle circle are all of the organizations that represent or sit on this steering committee. We also have community action teams, which are very much geographic focused. We have community action teams in the regions where we see the highest rates of maternal and infant mortality. And they have sort of sub-working groups, and they mobilize and organize themselves. Up at the top, you can see our Cherished Futures Collaborative, which is the work that I lead. And then we have a doula advisory committee. So we have a lot of just incredible work that's going on collectively across LA County. I put the website link, so if you want to read more or check out what we're doing, it's all on the website. So I want to be respectful of time because we are at, I think, the end of the day. But I wanted to just close with this quote by Bell Hooks. And it says that solidarity is not the same as support. To experience solidarity, we must have a community of interests, shared beliefs, and goals around which to unite. Support can be occasional, it can be given, and just as easily withdrawn. Solidarity requires sustained, ongoing commitment. And I believe that is what each of us in this room here are doing. We are building the solidarity, we're building this ongoing commitment, because again, what legacy do you want to leave? And with that, I will wrap up. Thank you so much. Here's my information. Please feel free to email or reach out if you need any further, or if you have any other questions or need support. I'm here. Thank you.
Please give another round of applause for Director Sherrod. Thank you so much for coming all the way over from Los Angeles to rally us at the end of the day. We appreciate all the work that you're doing in California, in Los Angeles, and we look forward to continued partnership as we move forward in our programming here in Harris County. So just to wrap up the day, first I want to thank all of you all. I know it's a Saturday and there's so much going on, but you took time out of your day to be here with us to address this important issue in Harris County. And I just want to, first of all, give yourselves a round of applause for being here, engaging with us. And the goal today was to begin laying the foundation, to begin the work on a collective level across Harris County to address Black infant and maternal mortality. We know there have been varying levels of efforts across the county in various organizations. Our goal is to bring all of that work together and to bring our collective knowledge and expertise and experience forward to advance addressing and reducing disparities amongst African Americans. I know that you touched on it in terms of solidarity. I want to build on that because what is so important is allyship across various groups, across various race and ethnicities. This is not a whataboutism moment. We are here to center what is happening to Black women and what we see as a national crisis. And what, we've talked about COVID, we've talked about other disparities as it relates to the health and well-being of people of color in this country. We know that all life begins with a mother. And our effort to address this issue means that we're looking into the future and we're looking at how we're disrupting generational poverty, how we're disrupting generational trauma and toxic stress. And so the work that we're embarking on today is so critical and so important. And I'm thanking all of you all in advance for your willingness to continue to partner with us. Before I go on, I also want to acknowledge Dr. Carlos Plasencia, the Regional Medical Director from the state. We so appreciate you being here today. Will you stand up, Dr. Plasencia? To be here today from the state and take in all of this information about the status of Black maternal mortality, Black infant mortality in Harris County, and to hear from the community partners in Harris County Public Health in terms of our call to action and raising awareness. We hope that you will take this back to the state and help and continue to help support us in the work that we're doing at Harris County Public Health. So thank you so much for being here. We really appreciate it. So what's next? So as we mentioned, this is our call to action. Harris County Public Health, as Commissioner Ellis mentioned this morning, we received $8 million to stand up a pilot project addressing Black maternal health within Harris County. And so we will be standing that program up. More to come. Dr. Erica Brown is leading that work with her phenomenal staff in terms of creating a home visiting program, collaborative work to bring together all of our stakeholders and partners. So we encourage you to continue to be on the lookout. We'll be sharing information about that program as we move forward, as well as information about the convening that we're going to stand up for partners that are in this space doing this work. I want to, Omari's gone. He had to catch a plane back. How powerful was it for him to be here in person and share his heart? And I think he's reflective of the work that we all need to do to support not just moms, but the partners of women that are giving birth or struggling with challenges of maternal health and well-being. And so he's not here, but I want to thank him in his spirit. If we can give him a round of applause for all of the work that he's doing in his activism to raise awareness of this issue. We heard from many speakers today, from physicians. It is so important for us to recognize that for many of us in all of our fields, including us at Public Health, we play a role in institutional racism. We did not create it, but we're operating in systems that were designed not for people of color, not for African Americans. And so it really is upon us to be aware of institutional racism and take heed of how we can disrupt that in the systems that we're operating in, whether that's public health, whether that's in a medical system. We heard from our physician panel today, and it's so important for us to continue to engage them, because what we want to see from our physician partners is that they're empowering and giving voice to women, African-American women who are on their journey in terms of giving birth to healthy and beautiful babies in our community. And so we want to support them. We're going to work hard to engage them, engage the institutions across Harris County, the medical institutions, to be able to give voice to and empower and have them drive. And if they don't know the information, support them in getting that level of understanding about their health and well-being and their baby. So with that, I want to close out this summit with a powerful poem that we heard Shawnee Benton Gibson recite at the end of the film. And it really is for us to honor the memory of Black women who have died, who've experienced complications in their maternal journey, and also to give homage to those loved ones who were left behind. And if some of you all were there last night, and the poem is called Gone Too Soon. Like a comet blazing across the evening sky, gone too soon. Like a rainbow fading in the twinkling of an eye, gone too soon. Shiny and sparkly and splendidly bright, here one day and gone one night. Like a castle built upon a sandy beach, gone too soon. Like a perfect flower that is just beyond your reach, gone too soon. That poem really reflects the heart of what we're experiencing. Many of us in this room have experienced maternal challenges, or we know someone who has. And so I really believe this poem pays homage. And please keep it in your heart and your mind as you embark on this important work that we're going to do in Harris County. Thank you all. Safe travels home. I cannot leave without thanking the incredible team at Harris County Public Health and U of H for putting on this incredible summit. Y'all did an awesome, awesome job. I don't have a cake for y'all this time, but I promise next one we will be. And the other thing I forgot to mention is we are holding a maternal health conference in the spring. And so more to come on that as we move forward through the work. Thank you all.